The idea in conducting these faculty development, see, regularly we are having revised basic course workshops, CASP and other programs. But in between, the idea in conducting these faculty development programs, again, to enhance the teaching quality, particularly our clinical skills. So how we teach clinical skills to our students. The other area is research. So that is why these faculty development programs were planned, and faculty are also handpicked for this program, so that who are effectively taking classes. Uh, of course, in rotation, the chance will become to other faculty also. Okay, so we'll start this program for today. One more thing. So this is the first program in Narayana Medical College which is going on live on YouTube. We have a YouTube channel, and this is the first program. Now it is live on YouTube. I think, Sir Shivkumar sir, I will send a link to you also. In your dental thing also, you can share it. Right, sir. Okay, so today's program, we are very fortunate to have Dr. T. Mohanapriya and Dr. Padmavati. So these two faculty are from SRMC, and in our AP Medical Conference also, we had them conducting workshops very actively. And ma'am, you both have got very good reviews for your workshop also. So I congratulate you, ma'am. See, whenever we request them, they are ready to come here. Yes, ma'am. Okay, so we'll start the first session for today. The speaker for this first session is Dr. T. Mohanapriya. So Dr. T. Mohanapriya is working in Sri Ramchandra Institute of Higher Education and Research as a professor and unit chief in the Department of General Surgery. She has completed her MBBS and MS from the prestigious Keel Park Medical College. She is an active medical education unit member, and she is the convener of various elective committees. She is involved in teaching general surgery to various students, not only UG and PG, but dental, nursing, paramedical for the past 15 years. And she has numerous paper presentations to her credit, publications and in various conferences. And she has been the organizing person for various conferences and programs in SRMC. She is an active member of various associations, all the surgical associations, IAGS, ASI, IMA, SHS, and other things. And she has 2 patents also to her credit. So she, apart from her regular surgical work, she is actively involved in medical education and research. There are several ongoing projects also on her name. So now she is pursuing her PhD in medical education. So a rare combination of clinician and medical education and research. So ma'am, Dr. Mohan Priya, welcome you. So for this session.
Good morning. Thank you, sir. Thank you for the nice intro. The topic given today is basically teaching clinical skills in ambulatory settings. So instead of talking a lot about how do you go for skills training, because you would have had those things about what is skills lab, how do you routinely teach all those things in your revised basic course or in your CASSP, I thought we'll talk about little about what is ambulatory settings, how we can organize ourselves to teach students when we are seeing patients, and little in between strategies what you can follow in clinical skills to change the way we teach them. Okay, so going on to these topics, I thought before going into the details of it, there are 3 terms which I'll prime initially before going into it. One is clinical teacher, skills, ambulatory setting. So we as doctors, when we are trained to be a doctor, but those who enter medical college have to become teachers. So once it's a little transition where that's why we go along all these medical education training, everything. So what are the features an efficient clinical teacher should have? This one? Yeah. So before that, my objectives, which we are also in this session, I'll try to cover up so that faculties will be able to understand about the need for teaching clinical skills in ambulatory settings. What are the models we can follow for teaching the clinical skills in ambulatory settings? What are the strategies we can follow? What will be the benefits, the challenges and barriers we would face both from our side, the patient sides and the students? And what are the tips we can follow to make the job easy? So now going on to the topic what I was discussing, whom do you call as an effective clinical teacher? This most of us would have already seen. A person, he should encourage active student participation. The problem is whenever, especially in OP, rather than your clinical ward side teaching, students just stand behind us, keep observing what we are doing. That will not be enough. They may not take in whatever we want them to understand. So make them actively participate. Try to emphasize on problem solving. How do you face this patient? What do you do for the patient? What if, because one patient is not going to be similar to the other one. So what you should do for each type of patient? They would have already finished their basic science. Integrate that basic science with how to see the clinical patients. And preferably, instead of just giving one patient, asking them to go to one room, examine it, observe them throughout. What are they doing when they see the patient? How are they communicating? How are they examining? So you don't only teach the psychomotor skills, you try to teach the other part of the skills also. And allow them to also practice. You don't just go do examination and say these are the findings. Make them examine. Make them do all the skills, whatever is required. More important than all these things, present state, communication. We have that AdCon module, right? So communication is what? Try to provide the best way to teach them AdCom is being a role model for them. The way how you talk to your patients, how do you talk to your colleagues, how do you treat the students itself will teach them how they should have their relationships with the patients. Now, basically be more of patient-oriented decision. This patient has caused diabetes, just don't treat diabetes. Treat the patient. He may have things other than that. So be more patient-related oriented rather than disease-oriented. Ultimately, have very positive attitude. ஐயோ இன்னைக்கு ஸ்டூடெண்ட்ஸ் வருவாங்களா, should I take class, I have so many patients, my OP will be busy, today is Monday, all those thoughts. Be interested in teaching. There's some good clinical patient coming, be so excited that you can show this patient to the students so that they will understand the disease much better than without seeing the patient or without having any active. So ultimately the most important thing is we have to be willing to teach, and we should also feel very enthusiastic about it. Next skill, this I think all of you would have already been knowing. It's not just psychomotor skill, it's not just doing some procedure. Skill as such is any action by a healthcare practitioner in direct patient care so that it will have an impact on the clinical outcome. The types of clinical skills, I'll just because all of you will definitely be knowing about it. It is basically intellectual or your cognitive, the psychomotor, attitude, and communication. This is the classification. You will be definitely knowing about what is each one. The other way of classifying would be better way of classifying, especially in this outcome-based education, what we are going following all these recent years, is technical and non-technical. So whatever we have been talking so far, this history taking, examination, communication, procedure skills, all these things basically comes into technical. The other part which is silently involved when you're doing all these things, like situation awareness. The student should realize how they should act in an OP, how they should act in a ward, how they should act in an emergency case, how they should act in an elective case. They cannot lethargically push a patient who is in sepsis or peritonitis, slowly work him up. He should know that a elective case, like I can talk only basically on more of, I may give examples more in surgery. A elective hernia patient who's got a nice uncomplicated hernia can be slowly shifted and posted. But a person with strangulated hernia has to be immediately shifted to her. This awareness they should basically have. How do you manage a present state? Communication, basically communication with the patient individually or working as a team. And decision making, how do you prioritize which comes first when you take care of the patients? All these things makes a big role. You will feel the impact. You have a good PG who has all these non-technical skills well, your life will be better, especially on a duty day. Most of us would have understood this, felt this in our life. This student is there, this assistant is there. My duty will be much more comfortable because they'll take care of these things. This basically happens because their non-technical skills are pretty good. Okay, this is what we were basically carrying. So basically you have deficiency. If we have, all the students are going to have, the chance of having an error or adverse effect will be more. You have to be very aware on what is happening. Likely when you have a very good skill, the chance of having all these errors obviously is going to be less. Now ambulatory care. We may just think ambulatory care is nothing but just an outpatient clinic. It's not so. Whenever the patient is not getting admitted, other places other than the IP comes into your ambulatory setting. So wherever the patient comes for a consultation, maybe a OP room, maybe a radiology X-ray room, maybe a blood lab where you check the blood investigations, all these, even the daycare surgery unit, wherever they are not getting admitted, you can take it into the ambulatory settings. Why are we talking about ambulatory setting these days? This has become one topic of interest in medical education because there is a change in way the patients are expecting things out of us. Patients don't basically want to get admitted for every problem. Initially, there are patients, I want to get admitted, put me to glucose, send me off. This was the initial attitude. Now it's not so. You tell me what to do, I will get it done in the nearby clinic. I don't want to get admitted. I have to occupy, somebody has to accompany me. There are so many things going into it. So better is going to have a daycare procedures or daycare treatment rather than getting admitted. Okay, so basically our treatment, what we are doing in medicine has moved on from an IP to the OP for most of the patients. So if we want the students to learn all the diseases, preferably the main spectrum of the wide spectrum of diseases, we would have to follow what the patients are following. Because it changed on to community settings, our teaching also has to move along with where the main crowd of patients are going to come, especially because we are following the outcome based CBME now. Okay, now for UG, we know we have got this EC, early clinical exposure. We are trying to expose the students once it enter the college itself, what is clinical exposure. So we would have to definitely be able to do it only if they take them through the ambulatory sittings, because IP only have very less patients. Remaining entire bulk patients will be, students will be only able to see in the other IP unrelated areas. Okay, and PGs, we know it's all on-job teaching. It's not that we have theory classes for PG where we sit and teach. They have to learn as they work. The more sincere a PG is, the more competent they are going to come out. And why again? All the changes in the hospital practice, what is the student requirement and what is the patient requirement. This all basically makes us go for ambulatory setting treatment. What are the changes in hospital? As I already told you, when you take IP, it's more of acutely ill patients, patients who are having a major illness, who are critically ill, who are the ones who are getting admitted. The what we daily see, everyday treatment, like a patient with a small folliculitis, a patient with probably little high sugars, a patient with an uncontrolled hypertension, or patient who's an asthmatic having a little exaggeration, people may come, get treated, go off. So what needs your routine care may not need a admission. So all these things makes us think, all these things, if the students have to get exposed, they have to come and see patients other than being in the IP alone. Basically, this is what we try to show even little in the learner doctor method. And students requirement, we know everywhere the number of students have increased. What the total number of students, what we had 10 years back is not the same. It's all as multiplied. So we need more patients. So sitting on only for what patients may not, all these students may not be able to say. And patients are not also willing to be examined by too many patients. So you have a classical case of CA breast who's getting admitted, getting operated tomorrow. She will hardly leave 3-4 patients to examine. At times they don't even leave these students to exam. That's why we are moving on from real patients to simulated patients and simulation for teaching clinical skills. So if it was OP, I may get 2 to 3 patients whom the students can examine, so they'll have more chances of examining the patients. And teaching all these things is not only for knowledge. Only by seeing more variety of cases, they will decide what is their future career, especially undergraduates. They come to surgery postings, or they come to a medicine posting, or they come to a community medicine posting. What is their exposure basically kindles their interest in that particular subjects. You make the best so you get more students into your field. This we have know. We are into a outcome based education pattern. So that needs more exposure of the students to the clinical environment. That basically happens only if they go all around and see. And this is what was the traditional teaching. Yeah, so this is where you have a bedside teaching over there. I'm sorry. You have a bedside teaching over there where there is one faculty surrounded by so many students examining one single patient. Okay, this is a OP side teaching where the doctor is examining a patient, others are watching. You have side rooms where they can move in so that this patient can be examined. There are various models how the students can examine the patients, which we'll talk in the later slides, just to show that. Now, what are the resources that are available in the ambulatory care, which we can use? Venues, which as we already spoke, it's not just the OP, but it forms the bulk of the patients whom the students are going to see, because we as teachers going to sit there. Okay. Next will be daycare unit, where you post a patient for a simple procedure which will finish off the same day and the patient will go back home. Emergency department, all clinical investigation, blood investigation departments, radiology departments. Not only our department, departments allied to us like physiotherapy, rehabilitation, counseling. We have multidisciplinary approach here. Most of the colleges have a multidisciplinary team. Once a patient got admitted, you will have a clinical nutrition person, you will have a physiotherapy person, you will have a clinical psychology patient, a staff nurse, and the doctor seeing the patient. Okay, so that's how invariably it is going on. So students should be exposed to all these things in the initial stage itself. Patients, it can be new patients who walk into the OP, or you will have old patients, the bank of patients, wherein a diabetic foot patient may come every week for a dressing to our OP, or a hypertension patient who comes every month for the drugs to the OP. So you already have a bank of patients whom you know will report on these days. So these patients can also be used. In spite of having real patients, still we have standardized patients, simulated patients where they can mimic patients which are cases which are pretty rare or which you do want to show to the patient at that time. Staff, most important thing, that's why we are standing here today, is these are the ones. How much ever resources you have, unless it's used in the right way to the right person, the right method, it's not going to be of any use. So basically, you should have a proper program design and a proper administration to plan all these things and execute it. And we clinical tutors should be ready to teach, as we started with the initial slide. And better is to reorient the faculties who are involved, especially people who are interested, so that you can use these ambulatory care settings for effective clinical teaching. What are the other resources other than the venues, the patients? What are the other things you can use? It's not that always you have to give a patient to a student to teach them. You can give their case sheet, read their case sheet. What do you think about this disease? Give just the history of whatever has been there, or whatever investigations already done in an outside hospital, the patient has moved on to you. Give those. Think what you think about this patient, so that they will start applying their mind. You will give a little of problem solving to them, so they can think over before going and seeing the patient. You can give their x-rays, you can give their CT scans, teach them how to interpret all these things. Or at times when you don't have a patient or anything happens, you can have videos which will demonstrate, especially for procedures, wherein they can watch a video, they can watch a real procedure, which itself will reinforce the skill twice. And diagnostic equipment, a proctoscopy, which is commonly done in our OP, would be a proctoscopy. Wherever proceeding, most of the patient, when once April, May comes, patient comes only with all lower GI complaints. So the student should know, for those patients, we are supposed to do a rectal examination, proctoscopy. At least once they should have watched all these things in the OP setting for a UG student. So all these things basically can be done in the OP setting itself. Now, what are the benefits of using all these things? Why should I strain when I have 100 OP sitting in the in my OP to be finished? Why should I strain and go and show all these things to the students? Part of these points we have already covered. Basically, because you have large number. When you see your OP will be 100, IP may be 10 or 12. So it almost 10 times. So you have more number of patients which will represent the disease pattern much better than the IP patients. And it's not just having acute ill, wherein you have a good abdomen mass, probably a patient with a liver abscess is admitted in the ward, but the patient is not going to allow the students to touch him because he'll have nice abdominal pain. Okay, so that may not be, though you have a clinical material inside the ward, they may not be available for the students to see. But if you have a non-chronic case or a non-acute case, the students can go and examine. And they can also follow, at times they can follow the progression of the disease. Probably they'll see a newly diagnosed patient, diabetic patients today. The same day, they may see a patient who has got some complication of diabetes like retinopathy or nephropathy. Same day, they can see a patient with having diabetic foot. So medical disease, having ophthalmic problem, having a medical problem, have a surgical problem. So you know what a single disease is going to see. Probably for a PG or a final year student, this may be simple. But for a first year or a second year, this definitely they will understand what is important. Simply smoking, what issues it causes. Tune them initially by showing examples that you smoke, what is going to happen. All these things probably you can reinforce in a OP rather than in an IP. How do you talk to the patient? Most important, especially negotiation. The patient may not be willing for examination. That happens for most of the time. Wherein more than us is a students who talk and convince them to make them get examined. So all these things come in over there. And at times, patients may open up their finances instead of enanga prachana. When you go and ask them what is the problem, they'll tell, I went to that hospital, I have asked to do so many investigations, I spent all the money, now I don't have the money, I'm not treated. Okay, just an open comment. So at times they give history other than what is required also. So they face 360 degrees the problem what is faced by the patient, the ethical issues, the social issues, the final aspect, everything they will get exposed over here. And it's not that we're going to just expose the students to all the patients going to come. We can select and keep. We move on to the OP at 7:30 to 8. You can select patients who are feasible, who will be good patients for the students to get examined. We can select and keep so that you will know. And you know what case you should show to a second year student, what to a pre-final and what to a final, and what is a PG case. So accordingly, you can segregate the case according to the student's learning stage. More students, obviously in OP you have more patients, more students can be accommodated, and you can, all types of skill can be shown to them. Best would be to make them actively participate. Just don't allow them to observe. This we will keep repeating again and again. And unless we intervene and model them, you cannot bring in all these changes into them. And what are the skills which will be addressed? All the technical, non-technical skills we are speaking before will be addressed. They can learn history taking, they can learn examination, they can learn clinical research. The cognitive theory can be well used. How to decide what to do. They will decide. The patient may start crying when they give a history. They should know how to empathize. They should learn professionalism. All these things they can learn as a whole integrated one. They'll also see the doctor doing all those things. That also they will learn over there. So basically, when you take your ambulatory medicine, it collates both what you do in the ward and what happens in the routine OP settings. It collates everything. The technical, non-technical, completely as an integrated package can be delivered to the students if used in the right way. It's easy to tell benefits. Does this all happen? We have lots of challenges we are going to do, especially in the OP side. Especially lack of time, more number of patients. So unless you have a proper objective and what is expected from that day session, this cannot be accomplished. So that we would have to decide. And never allow the students just to stand and observe passively. Actively involve them. Then it's not going to be of any use. We may tell, but you will see a case. You see, take them to that room, dressing room, examine them. So it may go unsupervised. See to that it gets supervised. Only then you'll know if they're really learning it in the right way. If the OP is much crowded, time for giving a feedback or asking the reflection may not be there. And many a times patients are taken for granted. We may not take a concern. Anybody who walks into the OP, you cannot assume that they can be examined by all the students over there. So that may not be so that may not happen at times. Last thing, keep in track so that what we teach today is in parallel with their curriculum. Unless you plan for the objectives, the last point also cannot be achieved. Now, what will be the barriers? Which we know basically. There are not a lot of doctors who may be interested in clinical teaching, basically because probably self-driven, it's not self-driven, or probably not much of recognition is there over there. You have lots of patients waiting there to be seen within a stipulated time. So that once you finish the OP, you may have to move on to the ward or go to the theater, operation theater to go on. So all these things are there. And it's not just these things. If you take on the clinical side, the demands are more. You would have to see patients. You have to teach students. Some may have administrative jobs. They have to go for those meetings. Some you basically have to go into research, and we are pushed to do because unless you have research publications, you cannot go in for a promotion. So all these things demands makes our work more difficult because for our personal development also we need time over there. And when you have lots of patients, the environment may not be clean, teacher friendly. It may not be very comfortable. You'll keep teaching the students. Somebody will come and put, sir, sign in this letter. Some patient will come and show the report. I saw you just half an hour back. Tell me what is this report. They will not understand that you are taking. Even when you're taking class inside a room, you will have people knocking the door and coming and disturbing you. Okay. So all these things basically have simple things which act as a barrier in your everyday OP teaching. And academic our side wise, basically we may not have adequate staff who can run both the OP and go on teaching. You should have a proper understanding of whoever is sitting along with your OP so that you can carry on this. And is everybody oriented how it has to be taken? You tell a plan, you give it. If all the 5 doctors who are sitting in the OP, are they trained for it? So constant retraining is definitely important to reinforce this. The thing is, if in case it's going to be private OP, if you sit a long time with patients, your patients may get restless. And others, if you go to the doctor, he will show you to the students. Don't go to them. This all can happen. It all may happen. So this all issues will come in when you are going for more of teaching. Patient related, I would tell there are lots of patients, but probably that day you may not have patients who are suitable for clinical teaching, which may be too much higher standard for whatever. If they're a second year student, you have higher standard of patients coming to them. So that all will be difficult to them. And as I already showed, we may take for granted. We may not always get the consent of the patient. Explain them that you're going to get examined by students just for the teaching purpose. If it's anything difficult for you, let us know. This generally doesn't happen, at least a verbal consent. Maybe follow-up me not there. Frankly, in IPUC, the patient gets admitted. If in case he is not an acute patient, The students can follow up the patient, got admitted, given some treatment, how did he recover from it, what was the investigation. This may not happen unless the students is coming for the posting continuously. The follow-up may get missed. Whatever the advantages can turn out to be disadvantages if not properly followed up. Okay. Student, though we teach, we put a plan, we put an objective, does all these students show interest? It may not be there so. So that will be a problem. And obviously we have most number of students. Initially there are 4 to 5 students coming in a OP. Now you have 30 students, then you have 30 students, then you have 70 students. So you should know how to segregate them so that it is effective managed. Okay. Overcome all these challenges and barriers, plan and effectively as possible so that you can manage the students, you can manage the patient load, and also see to that you increase the educational value. How do you prepare the workspace? Have a separate room, either for showing the patients or where the students can involve in some active self-learning. Okay, then preferably go and alert your colleagues. Today, this batch students will come. I will take this, you do this job. Alert your staff people also, sir. They are also aware that students will become. Sometime we have to dedicate for students teaching also. And preferably tell your patients also and see to that if 9 to 12 is a clinical session when students come, see to that you try to see the bulk of patients, leaving alone the patients who will be good clinical material. See of the patients, pile up these patients for the students. Remaining OP you can have it probably after 12. Decide your schedule, your planning accordingly. And tell obviously students that patients that you may get examined. Get at least a non-verbal consent before going on using them as study material. You have to tell the students, tomorrow be in OP number 18. Just don't finish off that. And that's my OP number. So tomorrow your posting will be in the OP. You all are supposed to come there, wherein you will see patients. This is how it will go. So prime them initially itself, because they may be in a sophisticated first year, they may be sophisticated sitting inside the classroom, seeing patients, going inside lab where everything is well organized. Here they're going to suddenly come into a public crowd. So better prime them before itself that this is what is going to happen, so that they are exposed to more responsibility, wherein we may tell a patient and explain what is this, ask them to go and take an history. Probably that's the first patient to whom they're going to go and ask an history. So prime them what is going to basically happen. Not alone, then you can also orient to them to what is the part in OP, where is the lab, where is the radiology department, who's the staff nurse who's responsible for the OPD, all these things you can have. If you think this is going to be an added thing, we can have a video of it, which is, it can be circulated to the students the previous day, so they'll get oriented to what is going to happen the next day, if they really see that video. Last is prepare ourselves. Whoever is going to get involved in this, plan yourself so that what is going to happen can get organized to it. So have prepared before itself what I'm going to teach to them, what assignment can I give them after this, or is there any self-study material I can give to them so that they'll come prepared. All these things can you. Tell your colleague that I am going to take class, you see patients, or I'll show this patient, you have to show these patients. So all these things you can tell them so that they'll be easy to handle the crowd and the students at the same time. And decide what are you going to teach them. Don't teach anything very low or very less. A student who already knows the basics, don't go again for the basic. They may not be interested. To assess what is the learner's level and decide accordingly the objectives of your session. So this basically just a thing to show whatever we decide about. You would have to decide what we are going to teach, to whom you are going to teach, the learner's level, what are the patients we are going to use. So all these things, and if you're going to have teaching scripts in beforehand, it will definitely help you for teaching them in a better way. Now, how do you organize? Putting all these things to put together, you can easily go and organize this one. So see to that you make the students actively participate in the teaching session. Only then it will be easy. Give them more responsibility. Show a patient, give them some time to go and interact with the patient and decide what is going to be done for them. Make them think what is going to happen to the patient, what all can you do. Especially if it's going to be a senior patient, you can initially ask the senior student, ask them, like probably a final year student or a postgraduate, you can allot them a patient before you seeing them, ask them to go examine the patient, give their findings to you. That all will definitely help them. Okay, and not alone this, patient not only giving their history and cooperating physical examination, at the end of the session you can ask the patient, how was this doctor, were you comfortable with them, how did they treat you. All these things you can ask in a subtle way to find out what was the professionalism of the patient. So what are the various models in which you can occupy the students, how a clinician and student can be occupied inside. There are various models which has been suggested. One such is wherein this one is the commonly happening, wherein the patient, the doctor will be, the clinical teacher will be examining the patient, the student observes. Here they'll mostly be passive. So this is what may be followed many a times when it's crowded. The best one way to have it in a three-way consultation where both the clinical teacher and the student will be talking to the patient. So you'll have a round. You can initially ask history, 1 or 2 lines, then ask the student, what else? Do you want to know anything else about the patient? Let the patient answer back. So you'll have some three-way consultation going on over there. In this case, you have to prime the student initially about the patient. Otherwise, they'll be lost over there. They may ask some unnecessary, unrelated questions. Hot seating is where the student talks to the patient and the teacher is a silent observer, seeing what he is doing. Then probably you can carry on and tell what was wrong, what is right in the right way. So this is the most possible method which we can use to have an best results, but it will be difficult, more time consuming. Sorry, yeah. Yeah, this is for one physician and one student. This is, if in case there are more students, one physician, one student is going to be very rare. You'll always have more students coming on to the thing. What all you can do, this is a common one, wherein there is a patient, there is a teacher, all the students stand around and observing what happens. Invariably with the senior most one who is going to take this session. Probably less number of students, this may be successful. Otherwise, you cannot actively involve all the students who are coming to the OPD. Supervising one, where the student examines the patient and he is supervised by the teacher. So you give a patient, ask them to examine, stand and observe what they are doing. This is all what we generally follow. Report back is you give the student to a person, especially this will be on somebody on the senior, probably on a final year. You can give a basic ulcer patient or a diabetic patient, ask them, take them to a side room, examine, ask them to come and report back, or you go inside the examination room and ask what they have examined, what do they think about the patient. This is breakout model where first all the students stand around the clinician, they examine, the clinician examines the patient, the students all observe. Later, each student, 1 or 2 students will be allotted patients where they take inside the room and they independently examine the student, which either you can again go and reinforce or ask them to reflect back at the end of the session. Now, these all things are possible only you have little patients and more hands to help you out. But generally what happens, you have more patients and more students, clinicians also sitting around. All you can do is students can shuttle. 4 people sitting inside the OP. Whenever I have a good case, I can ask students, come here, see this patient and teach them. Another patient has a good patient, which is a good clinical material, they can call the students around. So you can shuttle around to see what it is. Or you can divide them. I will see these 5 students go to Dr. 1, Dr. 2, Dr. 3, Dr. 4. So you can divide it. And inside that doctor, it's like one physician and several students use whatever method we have already spoken about. Anybody can use whatever they want. One wants to take all together, they can take. One wants to report back model, they can use it depending on the physician's plan. Flip-flop model where the students keep switching over from one person to other. 2 of them, I'll take for half an hour, go back to them, flap over there. Let them take for the next half an hour. You can follow that. The last one is tutor model. It's almost like your grandstand model, wherein there will be a senior most person who will take class for the students, and the remaining clinicians all will be disposing the OP. The whoever patients the senior doctor need not see will be disposed by the other doctors sitting in the OPD. So this is how generally you will be there. You have lots of patients standing around. There are students standing around, these 2 doctors seeing, the other doctors sitting around. So these students will observe what this doctor is doing. Probably he can give the patient to them, ask them to get examined, or you can also go for a supervised model of teaching them. This is a side room where the students can be examined. I mean, students can go and examine the patients. So what are the strategies inside this ambulatory settings you can follow so that the students will have the maximum benefit? Plan it. How do you frame it? Plan initially. This is what we have been talking. How do you going to plan, go for it? What are the teaching material you can give the patients before coming to the posting? How do you execute it? What are the methods you can teach them the clinical skills? How they can get back to us? Finally, is what have they taken in? That's more important. So you make them reflect and give a proper feedback to find out if the program is really, that day program is really successful or not. So it's almost a daily basis we would have to plan this one. So initially negotiate a plan. Better discuss with your learners before doing it. What is their learning level and what will be the objectives of that session is easily done only with that way. Decide what are the patients you're going to do. Make them jot down whatever they've seen in the logbook so that you will know if your objectives have been met. So only if you can do this, whatever gaps you faced in the first posting, you can probably fill it up in the next posting. Select the patients as we told. Decide on the objectives. See if they are little proper common presentation of particular illness. Don't go and teach them the rare presentation in the beginning. They may get confused. Always teach them the basics of the whatever clinical posting they are. Don't go for the rare ones, different ones, which may probably make them think the other way around. And if in case you can give them the materials before in hand, it will be easier. They can read and come. Like you can give what are the points they have to follow. You can give notes to follow up for the patient. What are the notes you can follow up the patient? There are various strategies for this also, where you can give an epitome logbook, which will have the history taking, the physical examination, how to interpret data, or you have a column where they can interpret the data, how to carry on the procedure, the technique followed, and if there is a disease, what are the differential diagnoses, how do you cut down and come to the main diagnosis, how do you manage the patient, finally educating the patient. That is very important. That should not be missed over there. All these things the students will initially have a little of pre-reading material followed up of noting down whatever's happened. Otherwise, you can have it as two parts, wherein first part will be pre-reading material, second part will be a logbook where they can note down whatever they have seen on that day. So this will be one way of theoretically reflecting what has happened. So you will also have a record of what has been taught, which we can see at a later time to check if our objectives have been followed. Now, the students may already have a knowledge of the case. Before they coming to the OPD, you would have to know if what is the prior knowledge they are having. Try to use that to teach on that day. Like how do you try to use it? Have a brainstorming. Before starting a topic, ask some questions related to the topic. If I'm going to talk on hypertension, if I'm going to talk about bronchial asthma, find out what they already know about it and then try to relate it to the patient whoever is presenting with hypertension or bronchial asthma. So that will help us to correlate whatever. And always after finishing off, debrief the student. You know so much already. These are the things probably you would have learned new today. So if you try to debrief them, it will reinforce it better. Always finish your session with reflection and feedback. Unless otherwise, it will not be of good use. How do you use the questions? Just don't go and tell what is this, what is hernia, or what are the drugs you prescribe for hypertension. Let it not be like closed-ended questions wherein you only have a yes or no, I know, I don't know. Let the questions not be there. Let it be open-ended so that the students will think and answer. Why do you think this is such and such a case? What are the points to tell that this is case? What made you think that this is the diagnosis? So make them think over and answer. This is not like a patient comes in, this is an ulcer, this is going to be diabetic foot ulcer. There are so many other reasons for an ulcer. Make them think, why are they thinking only about diabetes over there? Okay. And whenever you ask a question, the student doesn't know, just don't jump. You don't know? No. Give them time to think over. If the students ask a doubt, wait for some time for them to, if the students ask a doubt, don't answer immediately. You ask a counter question, some subtle question so that they themselves will think about the answer. This all will take our own time. We have to prepare for all these things, not as easy as that. And especially don't tell, do you understand? You don't understand these things? What is this? Such simple thing, don't be like this. In your previous experience, you don't know that there are certain points which maybe the students may find it difficult to understand. There you may reinforce on it. These things students generally don't understand. So I am repeating. Or somebody doesn't understand, don't feel bad. I will explain you again. Don't ask them who didn't understand, ask them to point out. They may not be always be comfortable. You will always have 10% of the population who won't understand and who won't open their mouth. You cannot make them actively participate. So assume yourself that they don't understand and try to reinforce it generally so that you don't localize and say that they don't. So what are the type of questions you know? What do you think is going on with this patient? These are common questions you can answer. Telling directly going and ask what is the diagnosis. Okay. If you're telling this diagnosis, why did you come to this conclusion? What is the presentation which made you think that this is the diagnosis? What else can be that? Are you fixed that this is only the diagnosis? What else is going to that? If the patient is having this disease, how is it going to affect its life? Can he live with this? What all he has to follow to tackle these diseases? Do you know what the patient thinks about the problem? Patient should know he's got a disease, what he thinks. That's all only you can get only when the student is going to communicate properly with the patient. Now, what did the patient come? What was his expectation when he came to the visit? All these things they would have to have communicated to the. So, what are you going to do next to the patient? And if they are given an opportunity to go and explain the patient what has happened, how would you explain it to the patient? These are the ways where how you can teach them to ask questions. Only if you ask, they will learn that next case they have to ask these questions to the students. Better explain as much as possible in an effective way. Don't try to tell whatever you try to know within that stipulated period. You should know what you should tell to students. According to the learner's level only, we should teach them. Sell it in small points, small chunks, so that they can easily take it. You will definitely know itself the way the students' faces turn out in the classroom. You will know whether they are following up or they are lost somewhere in between. And whenever you have a long topic, take a break. Try to summarize. Initially, you summarize. After then, ask the students to summarize. Can any one of you summarize what I have talked so far? So that will be a better way of reinforcing and waking them up also if somebody is not following it up. Okay, and always find it up with take-home messages, gets feedbacks. In feedbacks, you can get new messages. We learn things more when we get the feedback. The best way to correct ourselves is to take a feedback from the students. Okay, and how to treat with patients is the most important. You would have to act, as I already told you, you have to act as a role model to students to understand how to treat patients basically. So first decide whether patient is going to be throughout the talk is going to be on the bedside of the patient, or you need them only to a particular time. So whenever you examining the patient, whenever showing the examination skills, probably the patient can be there. Other than time, have a discussion without the patient also. You have to decide on how it is going to go on. And before coming, get the students examining, taking class, permission from the consent from the student, from the patient. This the student should witness. Only then they are supposed to get. They shouldn't take that. You can jolly well go and do, start examining the patient. Then see to that the students don't disclose everything. The patient has got probably HIV. He cannot go around, stand outside in front of him. That patient has got HIV. He cannot talk that. They should know that they should maintain the confidentiality of the patient. Better before starting, brief the patient also. Listen, there are 5 students who may examine you. If what this all they will do, I'm just going to teach them. All these things we should prime them before so that it is easy. And involve the patient as much as I already told you, get their feedback. Patients can give better feedback than the doctors. Task-based learning. You are seeing a BP for the patient. This itself can be a teaching mode for the patient. Ask one student to go and see a BP. See how he is taking the BP. Ask them, why are you tying the cuff? Where are you tying the cuff? In which posture should you ask the patient to be? Why are you asking the patient to be in this posture? Where do you check for the pulse? When do you hear for the sounds? Ask them to apply. Checking a BP is a simple thing which even the first year MBBS students is going to learn. But you should find out how much they have learned. So you can use these tasks itself to teach them few skills. And you can involve them actively into discharge summary, record keeping, or if in case in community medicine, they can go along with the nurse or the doctor to house visit. All these things will actively involve them in thinking over. This skill part, I'm just trying to highlight whatever you routinely use in skill training in ambulatory care setting. This 4-step Python step, most of you already be knowing, wherein how do you train a skills training. This is frankly speaking very difficult when you try to apply in practice, because what are the 4 steps? First, the teacher demonstrates the skills in a normal space without giving any comments. So if it's common thing, what we will tell is trying to put hand knot, wherein we first show the student how to put a hand knot, which all the students will watch. The next would be, I would try to put a hand knot in much slower space, telling each step what it is, demonstrating and also explaining each step. Third one, wherein the student will tell the steps, I will demonstrate. Fourth one, where the student performance and he or she also tells a step. This is Python's 4-step step, which is widely appreciated for using in skill training, procedural skill trainings. But the problem is, you will be able to do it in your ambulatory care settings, probably not in the same sitting with the same patient. You may not have 4 patients for demonstrating same skill in 4 patients over there. So what all the ways you can probably use it over here? All the 4 steps need not be demonstrated in the same patient. The step 1 and step 2, probably you can use a video, or step 1 can be demonstrated in real patient. 2 and 3 probably can be demonstrated in a skills model or in a video. 4th, where you again need a real patient or a simulated patient. So you can split it into things. But see, today everything happens within the same posting, not throughout the day, so that students will forget step 1 before they go to step 2. This is probably one way of doing it, and this you have to plan before in hand. Only then you will be used. So you should decide what all skill we are going to use this through this technique and execute it properly. Yeah. Now this is a video play pannu. Just few less than a minute videos. Video play பண்ணிடுங்க. Video play பண்ணுங்க. Just 2-3 videos to show how it can be done. Kindly don't check on the content of it. Video. Video. Not playing. Volume. I'll give voice over. Okay. Actually, this is a video. I think the voice is not. This is a video. Actually, he's a surgeon. He's trying to show the students on the side, OP side, how painting sound. He's just telling. It's okay. Yeah. Here, this all has been taken after getting written consent from the patient. Okay, it's our patients whom we have got written consent. Are you okay? I specifically took for a parectal, though it was a private area thing. These are very important where both the UG students and PG students have to know, because it's invariably overlooked. We see patients who get treated for piles outside. Invariably, it's not piles, it's probably a CA rectum. So we see to that most of the UG students at least see one parectal examination, one proctoscopy. So he is demonstrating how to do a parectal examination to the undergraduate students. In this, there's a student who is doing a certifiable skill where the students have to practice parectal in either in simulation or in a real patient. So every patient, all these 250 patients, students may not have a chance of doing parectal examination real patient. So we would have to demonstrate in simulation also. So he is being taught how to do a parectal examination, which the other students are watching. Ideally, this also has to be in patent forceps technique. We do it, but here for the thing of time, I've just had a 1-minute video of demonstrating this. Next is a proctoscopy where he is trying to what are the uses of the proctoscope. These things the students will watch. They have been already given reading material about it, how to go out. They have given videos to see how to generally do. Then they are demonstrate these things. These things, it's not a certifiable skill or an as such a competency, but they have to know before they move on from finish of their surgery postings. Now, this is a case where this patient has got a sebaceous cyst in the back. Okay, or it's basically infected sebaceous where it has to be drained. And this is a simulation model which we have created to teach both clinical examination of sebaceous cyst and also operative procedure. Because again, incision drainage of an abscess is a certifiable skill for us for undergraduate itself. So we are in a need for teaching all these students. So students will see possibly in a daycare procedure how incision and drainage is done, or we can show them a video how it is being done. Then they can also have hands-on. Obviously, they cannot have hands-on in the real patient. They can have hands-on on the developed simulation model to practice how this is being done. Then you can obviously just not using only real patients in the OPD. You can use the skills lab where urinary catheterization every student should have known, because once they enter their internship, they are asked to go on. So you can have hands-on training in a skills lab, how to do a urinary catheterization where somebody can demonstrate, then the students can have hands-on in the skills lab itself. The most important thing in clinical teaching, especially in a ambulatory care setting, is your 1-minute perceptor. You won't have half an hour to students to present, especially if you're going to have lots of students going in. Probably you can have one session where one student presents, all the 30 to 40 students are examining. But if you're going to have a small group, you want 5 students posted under, you want all the 5 students to present. Easiest way would be to follow a 1-minute perceptor. It may not always be within a minute, but preferably within 2 to 3 minutes or within 5 minutes, you try to have a short discussion about any clinical case. What are the 5 micro skills which are involved within this 1-minute perceptor? Get a commitment from the student. I ask them, what is the diagnosis? What is the evidence to tell this is the diagnosis? Teach them generally if a patient comes with these diagnoses, what are supposed to be followed. Tell them what was their mistakes, how they can correct it, all in a proper positive feedback way. Okay, so this will all go on. So you find out, give the patient a student, ask them to take the history and examination, get their diagnosis as I told you, find out why they told the diagnosis and what actually has to be told to the student. This is again a video. Here, this was a case of acute calculus cholecystitis, which was given to the student, and it was asked, patient, he comes in and asked, have you finished examining? What is the diagnosis? She said it's acute calculus. So I think it's acute calculus cholecystitis. He next diagnosed, because you seem to be very sure that it's acute calculus cholecystitis. What are the investigations you can do? She came forward telling, I will ask for an ultrasound or a CT, which will give me the, confirm me the diagnosis. She is right, provided her diagnosis is right. Acute calculus, probably initial investigation, ultrasound. But that is not enough. She should know that any patient who comes with the right hypochondrial pain with femur need not always be cholecystitis. Probably it can be a viral hepatitis, probably it can be a liver abscess, it can be gastritis, it could be anything. So you should think out of the box also. Don't just fix on to one single organ at all. And just the ultrasonogram is not adequate. You have to ask for blood investigation and other depending on the patient's status. So all these things you would have to explain within a stipulated of 2 to 3 minutes so that they understand. Next time they say a right patient with right hypochondrial pain, they understand that this all has to be followed. Next, that was for probably for UG student or PG student initial stage. If you're going to have a senior student or a medical final year MBBS student going to go for an exam, probably with them you can try this, wherein you give the case to them, ask them to SNAPS model, where you can ask them to summarize what was the case, give them the all the possible differential diagnosis and narrow down and find out which is rare. This commonly we do for obstructive jaundice. You give a case of obstructive jaundice. Generally, you only have to end up with giving a differential diagnosis of many things, where then with the patient's presenting complaint, we try to narrow down. If it's a postgraduate student, with the investigation, you can try to narrow down and come to one particular diagnosis. Find out what all the student was not clear, what was their doubts over that, and treat according to that. Then tell how it is going to be managed. And always finish this by giving them some material for self-study concerning that topic. Basically, you have to assess a student for clinical reasoning. You have to find out if they really have the tendency of applying whatever they have learned. How it is, you can have a short oral examination or probably a mini clinical evaluation exercise test. This is by giving them a small task and finding out how they are going to do it off. By mini CX, you can either do it in the OP or even in a ER, or if time permits, in a skills lab. You interview them, you can see how they are getting the physical history taking from the patient, how they are examining, how they are exhibiting the professionalism, how are they coming to the diagnosis, how is their clinical judgment. So overall clinical competence can be assessed by this short clinical exam, where you don't ask them, give them a complete patient, ask them to take the entire history clinical examination, give them short one. Like checking the BP itself also can be done as a mini CX in the OP side, where you don't have a lot of time to do an internal assessment, but probably a short time to check how is their clinical part. Now, encourage the students to reflect as much as possible. How all you can check, just the case present itself can be part of reflection. How they are going to do the case presentation. What was their idea? Share your ideas. Let them give their point. You tell what else can happen. All these things. The best way is, instead of saying, next time you see a similar patient, what will you do? This will itself tell what all they have understood. They just reflect back whatever happened that day so that it reinforces their learning, whatever they write out, see the objectives, whether it has been achieved. Both of you sit together and see whether the objectives are not. Check their logbook in their presence and tell them if all these things were achieved. You can check it out and give them topics they can go back and read. Feedback, most important is end of it, try to give feedback. Only then you know. It's like commonly you sell. Unless you know where your arrows are going, you cannot learn archery. So students should know according to where they are going. So feedback is the best way to find out what results we have got and what the actual results were. What was in the results outcome, what we expect and what the actual results. You will not know until the students going to come back and tell you what has happened, what they have got it. So what are the basic 3 questions the feedback should answer? This is for the student's point of view. Where am I going? How am I doing? How am I going or how am I doing? Next is what? All these things should be expected to be answered. And this preferably you can do it in front of the patient only if it's going to pertain to the clinical findings and thing. If it's going to be anything other than, preferably don't do it in front of the patient. So what are the types of questions? What all it has to be there? Try to be more descriptive than not being evaluative. You are not interested in the patient. That's not the way to tell it. Tell when you are asking that question, that patient, I saw you didn't have little eye contact with the patient. Was there anything that was sorry? Was there anything that was disturbing you? This is the other way of giving the feedback for them. Try to be. Don't hurt them. It may make the person students more introvert. They may not turn up to things the next day. Next is, instead of giving a generalized one, today you job, you present well, that is not fine. You can probably point out where good job, especially if it's going to be things like communication and adcom. When that patient broke down, I saw you showing good empathy to the student. When you're trying to do this examination finding, you did it properly as it's been taught in the class. All these things you can do. And preferably don't focus on learners issue, like somebody has an issue with the language, somebody has a problem with the accent. Don't point it out straightly. You can tell. When you're taking history, try to be little slow so that the patient will follow you up. Make it as subtle as possible so that they will follow it up. Time it properly. Don't wait for the entire session to over, or don't wait for the entire posting to over. Last day, don't call them and give a feedback. Try to be in between. It's the same day, within the same day itself, in between, try to give it as much as possible so that students accept it and absorb it well. And don't give lots of information. Try to be as much as focused. That focusing is possible only if you time it properly, because you're going to give it in the last, you'll obviously have lots of things to be told to the patient. And see to that if the goals have been achieved. Your objectives may be different, but what you're expecting in feedback shouldn't be different. Okay, see to that according to the objective it is there. And obviously the most important thing is problem learners. With them you have to be very clear, especially don't make them more problematic by giving too much of negative or being very strict with them. You should know how to handle them. And if there's going to be basically problem learners or slow learners, don't leave it off. The next teacher will take it. Take it as our own responsibility and we have to teach them. Okay, and you need not fix it for single patient, as I already told you. You can have it over several patients. In one patient, you can check about how they go for history taking. In one patient, how is the examination done? So you can one patient given one comment, because their performance has to be consistent. Only then our goals are achieved. Now, just a small example, almost last few slides. One example how you can have a teaching session in the OPD basically is like giving third year students are in your posting, asking them to examine a patient with musculoskeletal problem. First itself have a brainstorming to find out what is the learner's level of knowledge. Next you can ask them, next you can allow them, the student, to go and interview initially probably 2 or 3 students can join together to go and interview the patients, and then probably one by one or one single student go and examine the patients to check what are the clinical findings. Then they come back, present to you and reflect whatever they learned for it. This can probably either beforehand they can have a theory topic on it, or followed by it in their routine theory postings they can have a didactic lecture or interactive lecture wherein they learn about it, and finally give them proper feedback of how it has been done and evaluate them. Going on to daycare, this is mostly of ambulatory care, the OP side and the imaging side. Daycare you have patients where you do simple procedures who stay for almost half a day. So you can have 3 to 4 hours where the patient is staying there ideally, which can be used for clinical teaching. It can be used for physical examination, it can be used for history taking, it can be used for teaching informed consent, what are the post-op care you're going to give, patient education, all these things can be done. Actually, it will be a more of holistic approach wherein the patient moves in, gets a consent for getting operated and goes out with patient education. The entire thing of clinical approach can be taught in a daycare procedure. Okay, so you can use that 3 to 4 hours which is going on waste to start from pre-operative assessment up to the patient going back to the community. Here again, it's a small video where one faculty is doing a small subcutaneous swelling excision where he is giving local, and you have a student assisting him just for the sake, wearing a glove and doing it. So he will be examining the steps where the other students will also examine. This also is done after getting the patient's consent. So basically how the cycle of learning in ambulatory setting goes on, you define the objectives and also decide how you are going to assess them at the end. You organize the clinic, preferably give a room, decide who are the patients all before it, provide, give a orientations to the students and to your colleagues what is going to happen that day, and you decide who are the patients going to get, how much time you're going to allot for taking the class, how much time you're going to allot for seeing the patient, decide all those things, have a proper case presentation and discussion with the students. At the end of it, give a proper feedback for the students so that you understand what they have got engulfed in this thing. And ask the students to reflect whatever they are there. You also can decide next how you can plan for the next session, decide planning on this. So this is just a rough graph to tell how it all went on. So ultimately in an ambulatory setting, this is just a thing of what all each one is going to pursue. Basically learner, they'll see lot of case patients, lot of presentations, both acute and chronic. They'll have a proper holistic approach being seen, right from epidemiology, treatment, health education, what are the other aspects of it. They'll have proper supervision and a supervision where they can actively get involved. Patients also feel well, they'll have more, they can ask more doubts to the junior doctors than to the senior, and they feel that the doctor has spent more time, they're going to take it in the right sense. And for us, frankly, it's mostly of non-monetary gains where we feel once you take a good class and students give a good feedback, you have feel much better, you have increased proficiency, you have increased enthusiasm, you have that self-satisfaction of taking a very good class, and also patients also may feel that it's good. So how do you, what is the final thing to have if you want to set up a ambulatory resource in a new venue? You decide what is the objective you're going to plan the ambulatory setting for, what are the level of students to whom you're going to do it. The institution has to have a support, have a steering committee which will plan how to execute these ambulatory setting, and you should see who are the patients you can get involved in this. If it's going to be surgery OPD or medicine OPD, you cannot have it in super specialty. You decide which are the OP patients you can involve it. Find out which place in the OP you're going to use for teaching. So you can commonly have OP which invariably be crowded. So you can have a place nearby it where you can use this for the ambulatory setting. And is there anything we have to do in beforehand? The study material, resource material, anything you have to get ready for the students, a logbook, all these things you can probably ready. And preferably have good faculty development programs in between to train the faculties, and preferably train your teachers. A clinical tutor, whoever is going to be available in the OP should be there, and give good opportunity for the students to reflect whatever they learn, assess them properly, and give a good feedback so that the students may come back next day for having a better class. These are my references for a little long topic, and my acknowledgement. Thank you. Any doubts? Most of it was little self-explanatory. I just wanted to put a lot of things inside one single topic. If there's no doubts, then I think ma'am can take over for the next topic. Probably you can have some discussion at the end of the second topic. Thank you.
Yes, ma'am. ఇప్పుడు ఇక్కడ పెడితే ప్రాబ్లం ఏం ల్యాప్టాప్ ఇప్పుడు ఏమన్నా ఇప్పుడు మేడం ఆడ మార్చుకోవాలని మేడం లైవ్ లో మేడమే కనపడాలి సార్. అంటే అన్ని మనం అడ్జస్ట్మెంట్
సెట్ చేసి అది చేసి
అటు పెట్టుకోవచ్చు కదా పోడియం మనం కెమెరా పెడితే రెండు ఉంటే బాగుంటుంది దాన్ని బయట పెట్టేసి. Yeah. Okay, so we'll be starting the second session. Hello. వస్తున్నదా లైవ్ వస్తున్నదా? Yeah. We'll be starting the second session. So tea will be served into the hall only. So you can sit here. So we had a wonderful first session about the clinical skills. It's not audible. వినపడలేదంట. వినపడలేదు. Hello. Hello. So now, sir, still I think there is disturbance.
హలో హలో
హలో హలో సో ఐ థింక్ ఇది కూడా డిస్టర్బెన్స్ ఉంది. సుజిత్ ఇది కూడా డిస్టర్బెన్స్ ఉంది. ఇది డిస్టర్బెన్స్ వస్తుంది. హలో 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 హలో
హలో హలో హలో హలో
హలో
హలో హలో హలో హలో హలో హలో హలో హలో హలో హలో హలో హలో హలో హలో హలో
హలో హలో ఓకే యా ఓకే డన్.
హలో
Welcome you to the second session. We had a good session on clinical teaching skills in ambulatory setting. Now, so this second session is the most happening one, the research in medical education, like research in our respective subjects. Again, in medical education, also a lot of research and lot of PhDs are being done. Now, the speaker for next session is Dr. R. Padmavati. So Dr. R. Padmavati is working as professor of Department of Physiology and she is Associate Dean for Postgraduate Studies at Sri Ramchandra Medical College and Research Institute, Chennai. So, ma'am has obtained her MBBS degree from Bangalore University. She has done her MD Physiology from St. John's Medical College, Bangalore, and PhD in the field of environmental health from Sri Ramchandra Institute of Higher Education and Research. So, Dr. Padmavati is involved in teaching physiology to undergraduate, postgraduate students, and dental paramedical students for the past 20 years. And Dr. Padmavati has a passion for teaching and research activities. She has participated in the execution of innovative integrated preclinical curriculum and formulation of MD physiology competency based PG curriculum. She is currently guiding 6 doctoral students. She has completed advanced course in medical education, and she is the preclinical member of NMC curriculum committee of the institution. Her primary research involvement has been in multidisciplinary projects in the areas of environmental physiology and occupational health in various public health related research projects funded by national and international agencies, including the ICMR, Ministry of Environment and Forests, the World Bank, WHO, USCPA, NIH, and USA. She is also pursuing research in the area of medical education. And additionally, she is pursuing research in the area of yoga in anxiety and depression. And this project is being funded by DST Satyam Group. And she has received various awards such as Saroj Jyoti Award for Young Scientist Award from Women's Doctors Association, New Investigator Award from ISEE, Vancouver, Canada, and research publication awards and several best papers. She has presented papers in various national and international conferences and has several publications, more than 115, in national, international journals, chapters in books, a reviewer of Guyton and Hall, textbook of medical physiology. She is an active member of various professional internal and external committees such as American Physiological Society, International Society of Environmental Epidemiology, Indian Medical Association, Women's Doctors Association, and APPI. So, a rich experience in teaching and particularly in research. So, just this one will speak over 115 publications to her credit. So, I request Dr. Padmavati R to come and give her lecture on research in medical education.
Thank you very much, sir, for the introduction. And I would like to thank Narayana Medical College Management, the Dean, and Dr. Mahidhar Reddy, the Medical Education Director, for giving us this opportunity to be able to come and talk to you about medical education. The purpose of this presentation is just to give you a bird's eye view on what is the scope for medical education research, and also to allay the fears if you have that how is it possible to do research in medical education, is it possible to do research, and is it see finally what is the ultimate end point of research is to publish. So will I be able to publish in a good journal? Will I be able to present these information in a conference? That kind of fears also I would like to allay in this presentation. And in 1 hour is not possible to cover everything about research in medical education, but I'll just give you a bird's eye view regarding several aspects of medical educational research. Before going to that, can I just have a quick the first thing I would like to also tell you is, please remove the hat of your specialty when you are in a medical education group. All right, so don't view yourself as a physiologist, pathologist, or a surgeon, or a clinician, or a physician. All right, so we are all teachers. All right, so let us now view everything as a teacher and not as a specialist. So that kind of openness has to be there when you're there in a faculty development program. We're all teachers. Fortunately or unfortunately, we have not gone through a B.Ed program. So we all finish our MDs and MS, and then we are thrown into the college as teachers without having a formal training in teaching. But whereas NMC has come up with this faculty development programs to give us some guidance on how to teach the undergraduate students. So can we just have a quick introduction of your name and the department? Please be seated, madam. Dentistry.
That's the requirement. Head of pediatric dentistry.
Dermatologist. Oral pathology. Then madam. ENT. Sir. So why don't you sit comfortably? I think it will be difficult for you to see and see the crowd. So what is your observation when we introduced all of you right here? What was your observation? You're all seated with your own colleagues and friends or the neighboring departments. Correct? You're not, you chose your seats like that, correct? So I think that is the general herd behavior, I suppose. So we generally are aligned to our specialty and our neighboring specialty. Probably phase 1 will all be together, phase 2 specialties together, phase 3 specialties together. So this is what we need to shed when we take up a medical education project. We should not think only about our specialty. Whatever we do, any intervention we do in our specialty is applicable to any other specialty. All right, so that kind of openness is what we need to have when we start thinking of research, not just thinking of research, even when you're teaching, we need to have that, because that is when integration comes completely. So the objectives, like we have objectives for any session, the objective of this session is we need to identify what is the purpose of doing educational research and how educational research is different from the regular core specialty research, and what are the different opportunities and challenges in conducting research in education, and few tips. And I'll also circulate an article, I think, which has got circulated, which will be of help for ones who are interested in doing educational research. So I will be presenting in these lines why we need to do research in education, what should we research upon, how should we do the research, who are supposed to be doing this research, and where do you disseminate this research. So why do you think we need to do educational research? Can any one of you? Why is educational research required? Where is the need? So sir has gone to the last level. So if you do this research, finally it will translate to the community, to the patient service. Have you heard of the Kirkpatrick model? So we all have gone through this FDPs, multiple FDPs, and there's the Kirkpatrick's model, level of achievement. So the final achievement is to see that your student who becomes the primary care physician. Right now we are confining ourselves to the MBBS student. So the MBBS students' final ultimate goal is to become a primary care physician, and who should be able to do the required expected services by him in the community. He should be doing a correct diagnosis, management for a primary care. He is not a specialist. So that is what we need to keep in our mind when we teach the first year students or a second year or a final year. We are not making him a physiologist, we are not making him a pathologist, or we are not making him an obstetrician. He or she has to become a primary care physician, for which whatever is required from your end, you need to give him that information. So to know how our research is helping the students' final end goal. So keep your last end in mind when you start. That is what they say for curriculum. Keep the end in mind when you start writing the curriculum. Similarly, you need to have the end in mind when you start your research. So it is scientifically to underpin our education practice. It is required for educational development. So it's a developmental cycle. You develop an educational process, a curriculum or a teaching learning strategy or an assessment practice. You research it to see whether it is effective or not. All right. So if you really see the expertise pyramid, the lowermost, first thing is to teach. All right. And then developing the educational plan, coordinating the education. Then comes the management, the admin part. Then you teach about education, that is, you conduct the faculty development program. The topmost pyramid is researching. Though it is topmost, please do not have any fear that this is the topmost, but that is the simplest to do. Research in the medical education or educational practices is very simple to do, no cost. That is very, very important. We always have this issue about funding when you think of research. Most of the core specialty research, we need some funding to do research. But for medical education research, more or less, you don't need any funding, because even your questionnaires, everything now is Google form. You don't even have to spend on paper. So that simple is the research, but there's a lot of planning required before you embark into medical education research. The other important need which came up in 2019, that is both a challenge as well as an opportunity. To really see, NMC has introduced a whole lot of new things into the curriculum. A foundation course and an ECE in the first year, AATO throughout all the years, ATCOM from the first year to the final year. They said you should have a separate skills lab, you need to integrate. They have given a beautiful competency book which we can use as our handbook. They have brought in a lot of assessment changes, saying have an OSPE, have a formative assessment, have a summative assessment. So they have brought in a lot of new items or new elements into our curriculum. That means each element is a research question for you. All right. And the beauty of it is that this is being followed by all the medical colleges of our country. So it has generalizability. Always we have this thing about research is that whatever you say at the end of your research, is it generalizable to the other population? So we have saying that we have done the study in Indian population, it is different from Western population, it is different from other ethnic population because they have different anthropometry. Similarly, education also, if you do it in one particular medical college, they will always say this medical college, the way of teaching is different, the curriculum is different. But now, with this NMC bringing in this CBME curriculum and all the colleges more or less following it, probably with some minor differences, you will be able to say, I found this by in ECE. So that information, NMC can use it and send that information to all the medical colleges saying that if you expose the students for 90 hours of ECE, when they move to the phase 2, they are able to perform better in clinical postings. You'll be able to provide that valid scientific information. So it will be very useful not just for you for a publication purpose, it will be very useful for the governing body, to the NMC, for your institution, to know that, okay, this program is you're starting with family adoption program today. All right, so you're going to adopt a village. And so you can, that is an area of research. So one of the community medicine faculty can take it up along with the other faculty. from day 1 to day N, whenever you're finishing the family adoption program, just follow the students. Give them a questionnaire, give them a feedback form. That is all. Then whatever they give you as an information, their own perceptions about family adoption. They will say, I liked it, I didn't like it, I found this difficult, I found this extremely interesting. That is an information. Any information from one student is a valid information, unlike your scientific research, where the sample size makes a big requirement. You have to have a particular sample size to say, yes, this hypothesis is correct or wrong. But in case of qualitative research, one subject's information or two people's information is a valid information, because it is an information by that person. So even if 10 students say this, that is a scientific information, which is an information which is publishable, which is required for the policymakers. So that is how you need to view every program or every new element which you are doing. So you have so many new, sorry, so many new elements which have been introduced by the competency based curriculum. So we have so much of questions available to research on. Do it in phase 1, you can do it in phase 2, then combine phase 2, phase 3, do it only in clinical skills, you can do in the ADCOM, you can do in the family adoption program in health promotion. Now you have also seen the postgraduate curriculum. It's come in the NMC website. I hope you've all seen the new CBME curriculum. It's not new, they've structured it a little better, that is all. This is what we were teaching our PGs, but they put it in more structured way. So that can also be used for PG curriculum, can also be used. So as I was mentioning to you, that what the primary care physician needs to achieve at the end of 5.5 years is that he should be a holistic clinician, he should be a leader and a member of the healthcare team, good communicator, lifelong learner, and a professional. So any of these methods which you are giving in during your lectures or your practicals, you can see which one maps to any of these. So that is a research question. You do an ADCOM session and you can do a survey and you conduct a focal group discussion with the students and see how many of them have actually understood and are demonstrating that professionalism, are able to communicate very well to you. So you can map and say, yes, my program is able to achieve the goal or the role which the student has to achieve at the end of 5.5 years or in the end of phase 1 or phase 2 or phase 3. So this is how you need to view each element as a research question. Then came the COVID. First came the 2019 CBME. We were all already little worried how we are going to introduce this. Then we said infrastructure not okay. I am not trained to teach this. I am a preclinical person. How will I teach clinical side? I chose physiology and anatomy not to be in the clinical side. All these questions came in. The clinician said, I am not going to teach basic sciences. So this actually we were trying to overcome this by doing CISP programs, curriculum support program, by making the faculty feel comfortable on how to teach or how to implement these new elements. We were doing well. That is when the COVID came and all of us had to again reinvent ourselves on how to teach the students. Then came this online program. Online program was good, but had its own challenges and limitations. That was again another area for research, to know how the students felt during the COVID period when we were taking classes online. All 3 phases had to go through online. Clinical postings were being shown online, and the students were getting frustrated of not being able to examine the patients and see the patients. First year students were saying we were not able to understand anatomy without seeing the dissection. So all those challenges, and some said the online program did go well. It's not that everything was a challenge. They also understood the situation and they were able to utilize the online program and get the required knowledge. So again, COVID pandemic has given us opportunities on online teaching, how our healthcare infrastructure was affected. So medical education also is an area where COVID-19 pandemic affected, but at the same time, how we all cope with it. And that is again an area to work on. So this medical education research, is it only the faculty who needs to know about it? Or is it only the students who need to know about it, that what happened out of that research? No. It starts with the administrators. So what is the ultimate goal of the administrators is to provide an environment for a good and productive learning. So your research is going to give that information to your administrators and also to the governing or the nodal body, which is our NMC. For teachers, it's a direct benefit. They will know that, okay, the teaching learning strategy which I have used is useful to the student or not. All right. And assessment methods, is it good enough an assessment method for assessing the student of that particular competency or that particular objective? Students will give you a feedback on, yes, I learned it very well, I found this very useful. Health professionals, how to improve the practice. As sir was mentioning, finally, the healthcare facility to the community and to the patients is the ultimate benefit. So what are we researching on? As I already have told you those, we are researching on undergraduate programs. We can research on postgraduate training, which is much more under our control. You have postgraduates in your department. You can do a nice new intervention or a new element of teaching learning strategy and assess it, because it's much more, it's like, shouldn't call them animals, but it is more like an animal research where everything is lab controlled. Whereas UGs, you have, it's not that easy to manage all the confounders, whereas in PGs it's much easier. All right. Developments. This actually, as I was speaking to you this morning, he was saying there is so many FDPs being conducted. Why is NMC not still evaluating whether it is effective or not? So many faculty development programs, so many CSPs, so many revised basic courses, ACME, FEMA. How much has it benefited or how much has it helped in improving the competence of the faculty? That is again a program which you can evaluate. In our institution, we introduced what is called as PG training in teaching methodology. Normally, FDPs is there only for after you become a faculty. We thought let's have one 4-day program for the PGs. So we have a faculty development program for the postgraduates, and we called it as Ramachandra Annual Postgraduate Teaching Skills Workshop. So we conducted that program for 2-3 years, predominantly for pre-para, for clinical PGs for 1 day. So when we did that, then we collected feedback from them. Then we had a pre-test and a post-test also conducted regarding the educational principles. And then we assessed them on how they were taking classes in those 3 years, because they take classes for the paramedical students and also to the first year students in the practical sessions or clinical session. So we had that data with us. Then we wrote a plan on, we wrote actually a review or about development of such a program. So that was published. And then we did a pre-test process, all that material. Then we said that RAPS is indeed a program which helps the PGs in developing the teaching skill. Now we have submitted that for a patent or a copyright. So all this scholarship is possible with one program which we conduct every year for 4 days. All you need to have is when you're conducting a program, if you also have that thought of, okay, this can be also used, store the data, keep the data with you. Then you can later on analyze and do things, whatever is required based on that. So program evaluation is also an area for research. You'll be conducting multiple CMEs and conferences. Each one is a research question. How was the CME useful before and after? How has it increased? Collecting feedback. All this is very useful. So as I was mentioning about Kirkpatrick classification. So first thing is easiest is to do is get the perception of the people who are attending a program. Like if I collect the perception from you and say I conducted a 1 hour overview regarding research methodology to a group of faculty from different specialities, and I get a feedback from you regarding that, that itself is a material for me to think about. Then I see that, then I ask Mahidhar Reddy sir whether you all started some projects, whether there was a change in your thought process, and whether at least 10% of the faculty who attended have thought of one research question and they have started implementing that in their department. That is the level 2, 3. And then because they did that, they did a research in their department, their students have performed better. That is the next level. Okay, so each level is itself very useful, and going to the fourth level is the best, ultimate requirement of any educational research. Okay, so how to do this research? So this is how is it different from our core specialty research and educational research? Research is not different. You need to start with a research question, but how you analyze it or how you go through that process is slightly different between the core research and the medical education research. So if you see our core specialty, we all have done our core specialty research during our dissertation, and later on now we'll be guides for many of our PGs. We know it's a controlled setting and you already start with some hypothesis in mind. You know, yes, if I give growth hormone, the height of the patient is going to increase. You know that, and you will state that as a hypothesis and you will do a clinical trial. You have some idea regarding the end, and you can easily do an RCT. Clinical trials, when you go with the study designs, the best study design is an RCT. The lowest is cross-sectional, then you have case control, then you have cohort. The best study design is an RCT. So for a clinical trial, especially a drug trial or an interventional trial, the ideal study design would be an RCT. So RCTs is easy to do compared to the medical education research, because you cannot, when you're bringing in a new intervention, you can't really randomize the students. All right, because you will know, they will know. It's not easy. There's no placebo here. Okay, so it's not easy to randomize. To some extent, you can randomize by saying batch A will go through this, batch B will go through this. That is an randomization done by just the roll numbers. So you're saying that there should be a uniformity between the two. I mean, they are not too dissimilar. And very clear measurable variables is when you plan your medical science research. This is more or less, the variables will be like a social science research. You will first do a survey kind of a thing, and you will get to know, okay, especially say, for example, your family adoption program, when you want to know their perceptions, you just go with them and collect information, and then you will come up with a hypothesis or a research question. So initially it might be just collecting their information about what they feel about the family adoption program. How did they feel when they were talking to the villagers? How was their communication with the household members? If the student is non-Telugu speaking, how was he able to communicate to the household person? So all those simple things which they had difficulty, as well as how they overcome the difficulty. All that you will be just collating. Nowadays it's easy. You have to only record. Take permission, record the conversation, and then sit and listen to the conversation, and you can code it. So all that is what we do in educational research. Like any research, follow the finer thing that it has to be feasible. So one thing, ensure it is feasible, that otherwise it can be frustrating to the investigator. It has to be interesting. All right. So any element of CBME is interesting because no one has done it till now. It's new. So it's good to if every institution does. And you don't have to feel that, okay, ECE, Ramchandra has already done it. Why should I do ECE? Another important thing to establish a hypothesis is repeatability and reproducibility. There is no harm for Narayana Medical College to redo the same study here. Multiple studies will emphasize or will establish that hypothesis. Yes, 90 hours of ECE has helped the students to get the clinical relevance when they do basic sciences. That is the hypothesis. Ramachandra does, Narayana does, St. John's does, MS Ramaya does. All of them, if they show the same thing, that will make NMC say that, okay, ECE is there for good. Now we are not going to change it because it has produced the required results expected out of it. Or if again they say ECE is eating out the time of basic science classes, it is not bringing out that much of information, then NMC can revise the curriculum at some point. We have to feed that information to NMC. Unless we feed it in a scientific way, we can't just say, I don't like it because I need more hours for physiology. I don't want to send them to clinical site. Just saying that will not work. You'll have to show it scientifically. That is how it can help. It has to be novel, ethical. This is again an area which all of us have to be very careful as teachers when we do educational research. I'm the head of the department. I decide to do a research and I tell all the students participate. They will all participate because I am the head. They know I'm going to come as an examiner and they will be forced to participate. So if I'm going to be the examiner, I should not be taking those students whom I will be going as an examiner for. I should avoid that. All right. So choose an area where there is no such conflicts. Okay. So you'll have to be, that is a little sensitive issue where you need to ensure that the students are not forced to write. Another thing, there is ECE, there's foundation course, there's ATO, there is ATCOM. First year students, they come in, one gives one questionnaire, the other one gives another questionnaire, they will be fatigued. Like how we say even in the clinical side, you should not subject a patient for more than 2 studies. If a PCOS patient comes, you can't have multiple people coming and doing studies on that PCOS patient. She can be only be there for 1 or 2 studies, not more than that. So ethics committee will look at that. How many investigators are doing on PCOS cases? How many patients are doing on hernia? How many patients are doing on hypertension? You cannot subject the patient for more than 2 studies. So similarly, our students also are subjects when it comes to research. You should get an informed consent from them that yes, by answering this questionnaire, before that you will be asking their permission for participating in that study. So ethical issues, be careful on. Get the dean's permission before you do any study on students. And go through the ethical committee, because some of the journals will say medical education articles are exempted from ethics. You don't have to give the IRB number or the IEC number for the journal, but it's always better to go through the ethics committee process. Post also, it's not necessary that even sometimes after you have done the program, you want to now write it up as a paper. You can see like how you use the medical records data or the hospital data. It's already there. You're going to use it for doing some analysis. From the master health checkup patients data, you want to do some analysis. Ethics committee will give you the permission. It will just say blind the identifiers and use that data. Similarly, you have already done that program with the students, that intervention with the students. That time you never thought you have to publish. Later on you thought, okay, why I can analyze that data. You can go to the ethics committee. Ethics committee will give you exemption and give you the ethical clearance letter. But always keep the institutional office bearers informed whenever you're doing any research. It has to be relevant, obviously. It has to be relevant to what you're doing right now. So how you start is, first you start with a descriptive research and then you justify and then you clarify what it is. So what does this mean? Description is, say for example, problem-based learning. You just observe and describe the process of problem-based learning. Okay, this is how we did the problem-based learning. We gave a problem in the beginning and then we did this. That itself is a paper. When you describe the process, it's a process development. That is a descriptive type of research. Then you justify. Yes, problem-based learning is better than a simple lecture. Okay, and then you say, why did that problem-based was better than the lecture? You justify it or you clarify by giving your impression. This is how we do in any research. After we find the finding, you will see from the literature how comparable your results are, and then you say this is comparable with so and so study, and then you will also say yes, this could be the mechanistic explanation or the pathophysiology for this results what we have got. Similarly, in educational research, you have to also explain, okay, probably this problem-based learning stimulated that person in understanding that topic better than a simple lecture. Okay, so that is how you clarify your research. So step 1 is to find out the research problem. Instead of saying it as a research problem or a research question, frame the research question, use the appropriate method, and then you collect the data. The data can be, this is the Kirkpatrick model, as I was saying, a simple reaction. Just ask them, how was your problem-based learning? Today they've all have, again I'm using the same example as you've just started today. They all would have gone for family adoption program. As soon as they come back, send a Google form to all of them. How was your day one experience? Frame the questions before that and send. Now it's so easy to collect data. Just sending a Google form or sending a form through mail is easy. And I'm sure there will be student WhatsApp groups, which the faculty will be monitoring. So you will be saying, you can just post that Google questionnaire there and get their impression on how day one family adoption program they felt it was. So just simple reaction. It can be just a Likert scale. Okay, and then if you are ready with a pre-test, so before they go for the family adoption program, you can have a questionnaire. I could have actually done that here. I could have given a pre-test questionnaire to you all to know about the contents before I present this. I can have 5 questions, and then after you finish, I'll have the same questions again, as we all do. That is more a quantitative data which you can generate from. Then, see, once you teach them, as I was saying, ECE, they learn in the first year, and the second year faculty, that is the clinical faculty, observe them in the clinicals and say, yes, compared to the previous batch, this batch ECE has definitely helped them. They are able to understand my clinical, in the first clinical posting itself, the physician or the surgeon or the physician will tell us, yes, it has definitely helped them. Community medicine, they can start from here to, from the first year to the final year. Okay. And then finally, impact on the society. This family adoption program is a beautiful program which you can even see later on. So if you're going to have this village as your village, what you can do is after many years, you can follow up those households. That is how most of the Western studies which they are publishing, Framingham Art Study or any of those studies, if you see, the same households, they're following them up for years together. So if the same way, if you are able to do that for this village which you are now adopted, that is your gold mine for your core research as well as for educational research. So if you talk to them and say, my students are coming and talking to you, how do you feel? Do you find this as an interference or do you find it very soothing? All those things, that simple qualitative research from those household members is an educational research. So you can say, yes, the villagers liked that, the students often going to them and talking to them, how are you? How is your child? How, I mean, all those things, the regular health or any other, that itself is a useful thing. Like in St. John's, we have several villages like that, which we have adopted for a very, very long time. So for our students, they go to all these places and they being with us for many, many years since the college started. There are some villages which they're following up and they have their own satellite centers where these nuns are all posted there. So such kind of information is similar way I think CMC also has. So that kind of satellite centers where you can get information over a period of time will give you this information. How has it impacted the society? So as I was saying, for experimental research, you start with a hypothesis. You already state an alternate hypothesis saying, this is what is the direction. Then you write the introduction, methods, results, discussion, and conclusion. Whereas in a qualitative or this educational type of research, you first think of a problem as an issue or an element. Then you look at the literature for, has anyone done on these? And then you think of the intervention, say for example, foundation course or ECE, and then you will come out with an outcome as you are doing the study. So it's not that you already have your variables, measurable variables ready. As you do the study, you will know the lessons learned, and then you will come up with recommendations. Recommendations to your institution, recommendations to yourself, recommendations to the nodal center. So please, if people are interested in education research, I would urge you to go through at least a course online or offline on qualitative research. It really helps. There is a course by Samarth Group. You can note down that SAMARTH, which they offer online also, offline also, by a group of social scientists in Chennai. It's a very useful program. It will help you to understand the qualitative research, and there are, I think, some in Neptal, some in Coursera. There are several courses which is conducted. It helps you on how to see. It's not, interview is not something which all of us can do very easily. There is a structured way of doing the interview. Structured way of, sorry. There is a structured way of doing the focus group discussion, and how you do an in-depth interview, how do you collect diaries, how you do a stimulated recall, how you make case studies. It's like how you do case studies even for patients. Your patient case study, there is a structured way of how you report it in the journal. You'll have to write it in that structure of that particular journal when you want to publish a case report. Similar way, even for qualitative research, there's a structured way. And if you see, analysis is more on description and analytical induction, all right? And then grounded theory. These are the methods in qualitative research where initially you are just conducting interviews, you're recording it, and as you are getting this information, you will generate codes. From that codes, you will generate themes, and then you will say, this is the theory, all right? More or less like a social science research. I think the psychiatrists will be able to understand this very well. How they conduct interviews for a patient, and psychologists and psychiatrists, how they do those studies, and they did qualitative research is very close to psychiatrists. The strength of the quantitative research is very predictable, and you know there are n number of statistical techniques, a t-test or an ANOVA or a chi-square or a Mann-Whitney, anything you can use. And you will say, okay, my data is following a normal distribution, no normal distribution and all. But whereas in qualitative, again, it's a good thing also for us that there is no sample size requirement. You have, one patient gives you one information, that is an information. It's a valid information. You don't have to say that 10 patients have to give me the same information. No. So every patient's, every subject's information is a valid information. And it is sensitive to the context. So how are you conducting the interview? On what issue are you talking to them? And when you conduct an FGD, who is reporting? What is the group dynamics? All that will matter when you conduct an interview or an FGD. So finally, educational research, we depend on mixed method. That is, you will do both quantitative and qualitative. As I said, if you do a pre and post test, it is a quantitative variable. You do an interview, it is a qualitative. So you usually do a mixed method study. So what are the challenges we face is that we have different practices. There are schools where they'll have different types, countries, sorry, this is countries which will follow different. But at least for us now, as medical education teachers or medical teachers, we have a uniform curriculum across the country. So we have that element which can be used for research. So we can be assured of generalizability. It is not a challenge for us. If you see, all these challenges are opportunities. Factors beyond curriculum. See, sometimes you will say about SDL or a PBL, and you have randomized or you've said group A and say, for example, flipped class. It's a now very common thing. It's a useful technique also. When you do a flipped class, you are going to give material to one group who will view the material and come for the class. Other group, you're not giving the material and you want to compare. How are you going to make sure that this group B is not going to get that material? He might be his hostel roommate, or he might be his friend, or they will say, I have got a new video which was sent by this group A teacher. Please, I'll send it to you. How are you going to ensure there is no mixing? So these are certain challenges. So you'll have to think of some plan. All right. So finish the pre-test for both of them and ensure that you are giving the flip and conducting the class in the same time. Something like that. You need to ensure that, or probably it is not possible for a flip class intervention. I cannot randomize. I cannot have two groups. I will do it before and after. I will ask them how a flipped classroom was useful. So every intervention, there will be a new study design or a new thought process. So you can have those factors. There are non-standard delivery methods. Students are the study population. As I was saying, there are a lot of ethical concerns. You can't force them into participating into the study. You'll have to take their consent. You have to take the consent of the dean. You'll have to take the consent of the medical education department. before you do any of these studies. These are the ethical concerns. Qualitative research and publication. Generally, the thought is it's easier to publish if you have some quantitative data, quick to publish. Educational research, difficult to publish, no. Now, almost all the core disciplined journals are having a separate section for medical education. In addition to the hardcore medical education journals, IJMR is ready to publish medical education articles. NEJM, the highest NEJM Lancets are ready to publish. So all the journals are ready to publish medical education articles. So you don't have to have any inhibition regarding publication also. Yes, funding is a concern. There are no hardcore, like say for yoga, there is an Ayush, there is a Satyam, for alternative medicine, for ICMR, genetic studies, there are DST Splice, DST SERB. For medical education, still there is no one funding source. There are funding sources abroad in the US, that AMAE, American Medical Education Board, Canadian Medical Education Board, but there is a rider that you need to have a collaboration with one of those universities. But one good thing is that we don't need funding. If institution supports a little bit, that is good. Even if institution is not supporting, there is no money involved when you want to do a medical education research. As I said, even paper expenditure is also not there with Google Forms and all the technology help. All you have to do is have a plan and conduct it and analyze it. All right. So funding is not right now, there is no one funding source, but you really don't need that much funding for doing educational research. So first thing is to do a research question, then generate an initial hypothesis, an intermediate hypothesis, and finally research hypothesis. An example for it, does problem-based learning promote self-directed learning in students? This is your first research question. Then you will say yes, PBL improves or promotes SDL. Then you will say that PBL increases the amount of SDL undertaken by students in comparison to lectures. This is now you're coming out with a proper hypothesis. And final hypothesis would be where and when and what you're doing. So amount of SDL undertaken by medical students because you subjected them for PBL tutorials during that particular system in that particular year was greater than when you did with series of lectures in that cardiovascular system. So you have to first have this hypothesis. Don't just start a research without having a hypothesis. That will lead into trouble. So when you start with good planning, research will be a pleasurable journey. If you don't start, you just say, okay, I have to get a publication for my promotion and then I'll do something quickly. That won't be good. You plan it much early and then plan it in a very systematic way. Good planning, if you plan well, 50% done. It's half done. It's only the remaining execution which is left. Then you decide on what your variables are, the nature of training, whether it's a lecture, then you determine the cost, then the degree of SDL. So all this you can plan and then do it. Who should do the research? All of us, not just teachers. It's not only the pre or not it's only the para or not only the clinical teachers. All of us have to do this medical education research. Collaborate, that really helps. All right, so don't confine to your department, to your specialty. You are an education research as a teacher you're doing. So collaborate with another teacher from another department. That will really improve. And if you're interested in educational research, join for any of these programs or do these courses that will improve your competency in doing a research in medical education. See, PhD, one of the difficulties in PhD is to get a fund. But if you think you want to do PhD, do it in medical education. You don't need any funding. All you need to do is pay the PhD fees to that institution. Other than that, there is not going to be any expenditure from the expenditure per se. But as the topic, you already have an MD or an MS in your core specialty. Why do you need a PhD there? Add another area into your expertise, into your skill set. Choose another field. Medical education is a good field to choose. And if you are aspiring to become the administrator in any institution, having a PhD in medical education will help you to wear that hat of an administrator to run an educational institution. It will give you a good insights on all the phases and what to do, what are the educational interventions which are feasible, which are not feasible. So it really helps. So PhD is the highest which you can do for getting that expertise. FEMA, which is there in our institution. There is also a FINE, which is international. Advanced course in medical education. There are multiple courses in Coursera. Then NEPTEL, which is free from our country. There are multiple courses. There's a group by Sanjay Beri, correct. MEU India. He runs a lots of courses which is online, very useful. He also has a course called Medical Education Research Program, MARP, which he has every 6 months. So you can do any of those courses also with him. So where to disseminate? The high-end journals. Okay, so these are all the high-end journals which is accepting all the articles from medical education. You can present it in conference. Before going to the high-end journals, you can start stepwise. You can start first presenting it in your own institution. I have done this intervention, call the dean, call the medical education department, present it to them. They will be happy to know, yes, this has worked, this has not worked. These are, see, just presenting on what are all the logistics required for a family adoption program. That is it. That you can present. That will give me a lot of information to the institution. How many buses should I send? And how long should the bus wait? That is an information. So all that logistics thing is also a research. All right. And teaching learning resources, you can present it to the various conferences. You had hosted last time AP EduCon conference. So that is a good platform for people who are doing educational research to do. Then publish it to mid-tier journals. Don't go for the high end and get frustrated that it got rejected. Start with mid-tier journals, and then once you are confident in that area, go for the highest degree, go for a PhD in that profile, and then see that. See, we have come here as invited speakers. How did they choose us? I'm not saying I've become high profile, not like that. What I'm saying is we started somewhere here and we are now moving. Even here, I wouldn't say, see, learning is continuous. There's no end for it. I can't say I am now an expert in medical education. No, none of us can say for any field for that matter. But as we learn, there is a gratification also which comes in. When you do a PhD in that area, you feel very gratified. Okay, as a scholarship, I have got a highest degree. Other gratification is when you see your students performing very well, when you see it has impacted the society. See, what does the NMC want by introducing this new curriculum? It wants to see that change in the society. And as teachers, we have to give that support to NMC to get that final product. That is what NMC wants. Why is it changing the curriculum? It's easy to just continue with the same curriculum. They pulled in so many experts. They prepared this huge competency book. It was not easy. They had this vision in 2015, but finally it came through only in 2019. Even now there are changes. Then the COVID, they had this online module which they published. Then they said a logbook module. So they've been sending out modules with lot of effort, and we have to use it to bring in that change in the society. So you can do a poster presentation, then you can go for local recognitions, then get your educational materials peer reviewed, publish it as simple publications, then go for regional publications, then go for international index publication, apply for grants and awards, go for a copyright and patent if you have gotten a new thought and a new intervention or a new teaching learning technique or an assessment technique. It's easy now to do patenting. It's not difficult to do for a copyright. That has also been streamlined by the government very nicely. All you have to do is apply through that portal. So before you start, get some training, find a mentor who is already a FAMER fellow or something like that. Then ask the questions which you want to do. Start small studies to start with, although you aim high. Don't always wait for a perfect study. So always when you think of a research question, the first thing is how can it be done? No, even if you do this, it's not going to bring us big results. How is it going to be? So don't start with such negative or saying that this is not, even to our PGs we say that, no, what is this is already known, why are you doing it? PG's dissertation is only to make them know how to do a research project. We are not aiming at inventing something new or discovering something new. It is only that the student should know how to conduct a research project. So similarly, let's not wait for a perfect study. Everything, research can never become completely perfect. There will be questions which is the questions for a future study. Plan adequately, attend to the ethical issues, network with others in the field. Yes, it is hard work, but will be very pleasurable because it is part of your work. You're not doing anything separately. Because you're teaching every day, you're teaching your subject, you're teaching the new elements of the CBMA, because you're part of the system. So it's easy to do that study. And be the part of the 5 Ps of any research. The product should be a result of high level expertise. The process should be conducted in a scholarly manner. It should be peer reviewed. It should be disseminated. And after you do that research, it should be a platform for the next level research to happen. All right. Your research will pave way to newer questions. So the final bottom line of educational research, please understand, is the student learning. Yes, it helps us in publications. It helps us to go in for conferences, giving guest lectures. All that is fine. But that is not the purpose. Purpose is to improve the student learning and make them into competent healthcare professions, which will then translate into improved health of people and communities they serve. And it should be directed to know whether this is happening and how to improve it further. That is the ultimate goal or the goal of medical education research. Yeah, thank you. If I don't mind, can we just do a quick activity? All of you have been given some small booklet. I want you to write one research question, one medical education related research question. If you can go till hypothesis, very good, but it's all right. Just write one research question which you think you will be able to do in your department or in your phase or in whichever way, whichever thing. Not necessary, don't again be confined to your core specialty. You can do it outside your specialty also. PG, UG, program, whatever. One research question. Careful. Don't get up. Mic. Can anyone from this group, if you're ready with one research question, second, you can use the mic. This is the dental experts group.
How to create an interest in students to conduct a research work.
So sir, can you repeat the question? How to?
We want students to take research work.
Okay.
But how to create interest in them? Because most of them may be not interested.
Okay.
So to create interest in them, what are the steps?
So sir wants to know that how to stimulate the students to do research. So that is the issue which is bothering him. So how do you think we can go about this? So he has identified the problem. So first thing, in a qualitative, very beautifully, he has identified a problem. In a qualitative research, you start with the problem. Okay, I'm seeing that the students are not interested in research. I don't know what is the, so there is some problem in among the students, there is something which is hindering them from doing research. So he wants to know what are the factors which is hindering the students from doing research. So, sir, how should we go about that? No, you're already giving the answers, but that is the question. So, how should he conduct a research in that? So, how should he go about getting the answers? You're see this, yes, she's giving some answers. So, you can give a questionnaire to faculty also. You can give a questionnaire to students also. So, give a questionnaire or a survey form to find out what are what is their perception about doing research. From the faculty end, you can give it from few faculty saying that, as she says, some reason she is saying which could be the reason for the students not doing research. So, for your question, you will start with a survey. Simplest is to do a survey, a simple questionnaire you prepare, validate it, and then give it to all the students and faculty separately, students separately, and then what will you do after you collecting that? After you collect that information, you will code them and then you'll put them into themes, and you will say this is the topmost reason for students not interested in doing research. Then you can also do a focal group discussion. You will call some 15 students. You can even decide how the students distribution can be, some high performers, average performers, low performers, and then have them as a group and conduct an interview, a focal group discussion, and find out what are the important things which is coming out, why the students are not interested in doing research. And then the next thing you would do is present it to your educational board, and then you can see what are the recommendations or the solutions which can be brought in to stimulate the students to do research. And then you bring in that intervention and then see before and after. So you have series of research questions which you can answer. So, sir, so this is how it will generate. So he has come up, he had only a problem in mind. I want my students to do some research, but they are not doing. So how will I go about? So you're also doing a research, you're also bringing in a solution, you're providing a recommendation, you're bringing an improvement in the students, and you're bringing an improvement in the science. All of that will be achieved by proper planning. All right, sir? The next group. Anyone from your group can state a question which you thought of? Yeah, sure. Anyone? Both of you can. Madam, every a question is a question. There is no basic, primitive, nothing.
Comparative study of the present CBME when compared to previous existing medical education system when look at the outcomes, knowledge and skills.
Very nice. So this will be very useful for NMC. If you are able to generate that information and say, yes, CBME has improved. So how do you think, where do you think you should collect your data from? Ma'am, please be seated, madam.
This is somewhat like testing hypothesis.
Right.
So here that what the previous medical education system, one hypothesis would have been generated. So the outcomes is what we are doing today. Whatever world teaches. When we want to compare to the study about the new CBME curriculum, I want to test the hypothesis of previous system. So now I am feeling that I am not able to get the controls for that testing of the hypothesis. How to get that control?
So, yeah.
I can't test my old system of controls. So I am checking nowadays whatever this research topic is testing the CBME hypothesis. Whatever they given the things like the problem-based learning or small group or integrated, whatever. Already it is given some CBME curriculum. We are testing those things with that CBME 2019 batch students. Naturally, they don't know what is the previous system to give the comparative analysis to us. They are giving good. So all that research papers is going to come. This CBME is going to good. And how to test the previous is we are testing already some given hypothesis, but that there is no evidence.
Ma'am has already written a review paper on challenges on how to assess CBME. If you put that all down, it's a review paper, madam. What are the challenges on knowing how CBME is good or not?
Unless we see the outcomes in the society after down the line, 10 to 20 years after
Yes,
down the line.
yes.
So it's very difficult what we are studying today to implement this system to the student. So that 20 years, maybe my generation may not see the things changing with the system. Is there any shortcut?
Ma'am,
Prove or disprove?
the cardiologist will be so happy about Framingham heart study. If they were so impatient, they won't get that information, no, madam. No, but what you are asking is absolutely right on how to know that CBME is working or not, or is it useful or not. Better than you want to compare. So you want to call them controls and cases. Typical core specialty kind of research. You want to do a case control study. These are the cases. Those are controls. Absolutely fine, madam. Simplest way to start you can do is you have teachers who have taught the previous curriculum students. Say the ones who are right now in final year or even I think, yeah, close to final year or interns. As you said, old teachers like us, we have taught the previous years and we are now teaching the current years also. We actually had the clinicians when they came, when they were teaching the CBME students, the first CBME when it went to the clinical side, they said that batch students were better off in clinical postings when compared to the previous batch. All right, that was simple impression. The simple observation. Yeah, they said they were performing better in the clinical history taking, in the assessment of the patients, and they were able to give the basic science relevance to the clinical side. That was an observation which they was found. That's what, see, it's a qualitative research. So qualitative research will have that bias. Quantitative also has the bias, but from, if say I take from the medicine department, from the OG department, from the surgery department, where they first go to, as soon as they go to the second year, you collect that information from all of them. Out of the 30 faculty, 25 faculty says yes, 5 faculty, no change. It's all the same, I don't find any difference, but 25 faculty are saying it. So that is an evidence. Similarly, 25 faculty from every institution says that is an information for NMC. This is the simplest way to start, madam. The other objective way to assess, you have your controller section. They have the marks. You have internal assessment marks. You have the university marks. Internal assessment you have for theory and practicals. You have for theory and clinical examination marks. Compare the ones from there and here. You can also even do further in-depth to see the questions, how they have answered the questions. That will take time. It's hard work. So all you have to do is you have to sit down and see how a student, say a question, I'm giving you a physiology example. If I ask a question for a student on describe the connection functions of basal ganglia and add a note on Parkinsonism or something like that, or if I don't even ask add a note, I just say about basal ganglia, a non-CBME student ends only with the functions of basal ganglia. A CBME student says in the end, one clinical condition on Parkinsonism. He writes about a word on Parkinsonism. That means he is already bringing in the basic science and the clinical. He is able to bring in the relevance of learning basal ganglia because he might be seeing a patient of Parkinsonism. So that is what is CBME wanting us to do. When we take, though we are teaching again as old teachers, we are teaching like that. We are not changing our teaching pattern totally, but we are able to give them specific objectives and we are able to see whether we are meeting that objective and giving more emphasis on the clinical aspects, not hardcore basic science. I don't want to really know the indirect pathway, direct pathway of dopamine and how it goes. That is not a primary care physician. He needs to know there is dopamine deficiency results in Parkinsonism. Parkinsonism will have these issues because basal ganglia's function is to maintain the tone. That is all he wants to know. So that time, the relevant basic science for that applied aspect instead of going into the hardcore biochemical pathway or the physiological mechanism. So controller's office is an area where you can do research on to know whether CBME more objectively. You said that is subjective. This is more objective to see how it has improved. See where when we saw We started integrated curriculum in 2007. The pass percentage did not change, but the number of students scoring more than 70% increased. So the number of students who are performing better increased. So that was an academic performance indicator for us. To say that by integrating a curriculum, we started integration way back in 2007, even before NMC brought in. So when we did this analysis before and after, we saw that yes, the pass percentage more or less was the same, but what increased was the performance of the students increased. So you can't expect that P less than 0.05 statistical significance in qualitative research. 1% increase is an increase or an improvement. That's should have, and go ahead with that intervention. Next group. So can you be a little louder, or can we pass the mic, please?
Assessment of improvement in marks in internal assessment after, before, after implementation of ECE, madam. Early clinical exposure is monitored by students in second year, in previous students of second year, after getting implementation of early clinical exposure.
This is the answer for your question, madam. You can use internal assessment
Before
marks.
discussion only, I written this.
It's all right, sir. No. He is comparing the IA marks of students of that batch which did not have ECE with the students who are having ECE. No. How can you match on the variable you are interested in? You can't. That is not case control matching. Other variables should be uniform. They are also same students, same age group, same mix of all of that. You can't match them. Then how are you doing the ECE? If I say, for example, you're doing. Correct.
Clinical methodologies, we have controls now, at least for next 2 years. At least that batch still is there before 2009 students are there. Once these students goes out, very difficult to get it.
Ma'am, don't be too this thing about the controls. Controls is for more quantitative research. For qualitative, don't be very compelled to use controls. You don't have to. They can be their own controls, before and after. Sir? So 1 second.
Does teacher-student relationship improve the learning of the students? Even though it is
It's what you're saying is mentoring. You're now looking at mentoring program evaluation. Fantastic, man. You can do that. Again, you have to do an FGD or in-depth interview, talk to them, get that impressions, create themes, and say yes. These are the things which the students like. These are the things which the mentors like. These are the things the mentor felt it as a challenge. They're calling the students. They're not turning up. I have to go behind them. These are the things which we face. My mentee is not turning up. I have to repeatedly call. The other way, my mentor calls me all the time. My mentee calls me all the time. All that also is information. So that can be a thing. So, sorry. What happens after they go back to their departments is what is the outcome level 3. Sure, it is there with sir.
Is it possible to compare the India university results before CBMA and after CBMA? Because after CBMA started, they not taking consideration of internal assessment marks. Depending on they are university exams, can you take the pass percentage?
Yes. Yes.
Assess the.
Yes. That will be definitely, sir. The university performance also will help. Actually, if NTR University Vice Chancellor takes it up, he can pool all the colleges and have a big number also generated. But the university has to support.
students attend the classes regularly?
That is, if someone does that study and gives us the result, that will be published in Lancet, sir. That is what every one of us are struggling. But it is possible. It is not the saying it like that. But if you generate that interest, we first thought someone said SDL is difficult. SDL, we think it is difficult, but you should see the kind of things they come up with when they do an SDL. The kind of presentations, the kind of information the students bring in is phenomenal. That is when you realize that you always underestimate the students, that they will not, but there are, okay, handful of them are there, but when the others do, this handful also will look at first SDL, you will have, say you have 20 students, only 5 might speak, will come up with all the information and present. And when they are presenting and when you also show that excitement, oh, you did a fantastic job, I did not know this, you got this information, and then the next 5 will come up in the next SDL. Then the next SDL, the 90% will come in. 10% will anyway have to have that whip with us or something to get them saying that this is part of your IA. If you don't come, I will give you negative, your marks will be reduced or you will not be eligible for university exam. Those kinds of things we need to do for the small number. But more or less, the students are enthusiastic when you actually give them opportunity for them to come up with question and answers and come up with some preparations. We conduct some project for them by giving them case studies. So they come up with beautiful, they enact. We tell them to do the what is it called? Role play. So they do role plays and they do it very well. And they prepare videos and their technology is very good. The way their skills with using the technology is very good. So they prepare that and do it. It will be very useful. Yes, ma'am.
Introduction of MCQs
Huh?
has affected the student learning
Huh?
poor performance examinations.
So that you are stating the hypothesis. Okay. Yeah, true, true.
Can be a research question.
It is a research question.
This was my personal experience with the students.
That's right. Like how sir had an experience.
Earlier one, their performance in the examination will be much better than the batch which is going for examinations. That was one point. And secondly, the second year courses have been reduced from 1.5 years to 1 year. That has also affected the
This
student
is-
performance much in the examination.
True. That I think phase 2 with the current, but I think it's only for 1 year, madam. The next year onwards, it's corrected. The next batch, not year, the next batch onwards, they are getting the 12 months. It was only for that COVID period where they were reduced to 10 months because of the COVID issue. Otherwise, they are back to their needed hours, and even the phase 3 are also getting the needed hours. They have distributed it. So you think an assessment method has hindered the performance of the students? That is your question. So one thing is, by showing the numbers itself, you are saying yes, the marks itself is showing that there is a reduction. So you'll have to find out why there is a reduction. So you have already described your question. Now you'll have to justify and clarify by talking to them, by saying why they have not, is that their preparation was inadequate, or is it that in our classes we have not emphasized on points which they need to take in for an MCQ. See, MCQ is, a person will perform MCQ well if he has read it properly and correctly and understood and read it. Madam, you are bringing teachers to trouble, but anyway. So by talking to students and the faculty, you can get the solutions for it and then accordingly change it. Yes, ma'am. Any assessment method is a research question. Teaching learning strategy is a research question. The last group, I think there are psychiatrists in that group, if I remember correctly. For you, it is a very easy thing to do qualitative research.
Patient satisfaction levels in the OP after changing the teaching techniques.
So yeah, the final batch. Yeah, patient satisfaction can be there at different levels. Even your family adoption, you can talk to them whether they are satisfied with this introduction and all that. So that is a good thing. And how do you plan to do that patient satisfaction?
Feedback questionnaire.
questionnaire, in-depth interviews, FGDs. FGD has a higher value in qualitative research compared to simple survey questionnaire. Like how we have cross-sectional case control, cohort and RCT, similarly you have survey, in-depth interview, FGD, all this as grounded theory as the highest. That is nice. Any other? Yes, sir.
Intricate things of the theory part of anything. You quoted basal ganglia, the direct pathway and indirect pathway and all.
Physiology sir is offended.
No, not that. My question is, say, madam, what she raised a question, MCQs, our observation also, after introducing MCQs, nearly 20 marks of the MCQs, they are not performing well. My observation is the structured question of MCQ, the question is itself, we are giving very core theory of that particular topic. Unless he knows the theory well, he cannot answer. So I think it is a paradox. You need not go to the core of the subject, but at the same time, the student has to face the MCQs.
Sir, I agree with you. At the same time, I also want to emphasize on this point that the ones who prepare the questions or who are setting the question paper should be given clear instructions and the syllabus and the structure to set the questions. So because you will be teaching one thing to the students and they should not be exposed to questions which they are not taught. So that is the reason why for every question, MC question, you should calculate the difficulty index and discriminatory index
Yes,
and all
ma'am.
that. Ensure that actually for according to the NMC now, that MCQs should be coming from only the core and not the non-core. You can have one or two short questions from the non-core, but MCQs have to be coming from the core topics only. So you should not ask questions from a non-core topic and expect the student to answer that MCQ. So it is actually again the onus is on us on how we prepare the questions. So setting the questions is very important. See, that can also come out as a problem in your study. When you're doing a study and saying why the student's marks has gone down is because we have not set the MCQs correctly. Either we have set the questions from a non-core topic or a topic which we have not covered in depth and asked that question in MCQ.
Sorry to comment, madam. The university exam question, especially MCQs, I think the paper setter is not following the guidelines which has envisaged by the university or NMC.
Correct.
And the difficulty levels and the STEM as well as the distractors
Choices.
are too
Correct.
difficult at the level of student to answer.
So that I think the university, the NMC has to give that instruction to all the universities to follow a proper pattern based on CBME and prepare. For us, we are at a advantage because we are the university ourselves and we follow the same pattern in the IEA as well as the university exam. And it is completely under our control. We are properly controlled, madam, not the cases. So that way, we are at an advantage. Correct. But they have to follow, no? The question paper setter has to follow the blueprint. Blueprint is a must. When you're sending a question to a person to set the question paper, you need to send the blueprint. Madam, make them do yoga. I think that is the reason why they have introduced yoga, no, madam. 20 hours of yoga in first year, 26 hours. Again, see, we have to find solutions. How we do that with our own children, we'll have to do it with students. With two of them or one of them, we are able to do. Every day we are doing the teaching learning strategy at home, no matter. Huh? Ah. Okay. ma'am.
Student and the patient ratio has drastically changed for the past 1 decade, madam. Is there any new teaching model where we can improve this particular subject, madam?
We have.
Basically, that's why simulation, the present NMC, all the clinical subjects, simulation inside it.
Okay.
Whereas you can use videos also, whichever doesn't need the student to practice, you can use videos. They can watch over it or read the theory aspect of it. Where they need hands-on, only simulations.
Simulations.
Because basically it's became very impaired. It's all evidence-based and patients may complain. Even to just touch and see how the finger is, the patient may complain. In that case, only simulation can help. You all have to move towards it. So
Skills
that
lab has to be established at every college.
Otherwise, we cannot think with competent clinical doctors.
Okay. Thank you, madam.
When we are accommodating 260 students, not less than 250 to any college after 2 3 years of they are going for. So why can't we make it that we should, no, that is not possible at the level of medical teachers. So taking only 150 or 100. So when there is a 250 students college, why can't we make it a 6 hours hospital program instead of 8 hours or 250 to be covered in the clinical side? Theory part lectures can be common to 250. When you go to the clinical part on the patient side, so why can't you make it as a 6 hours hospital program for 125 students? Like maybe 2 hospitals. Like that's why we have rotation. All the 50 students don't go to clinical posting at the same time. Hardly for us 60 to 70 students come. That too only in final year. You take my phase 2, I get only 30 students. Those 30 students don't go to the same unit. They are split into 8 again. So ultimately, maximum student I handle for 3 hours will be only 5 to 6. Which I think is definitely possible. Maybe all the questions to have see one patient may not be possible, but I can definitely give proper attention to those 5 to 6 students. Every unit will have 2 to 3 doctors. So, except probably on your operative days, I'm talking about surgically. Otherwise, I think that's why this rotation posting comes in. Probably that rotation also, that will be inside our. If you want to talk things which are under our control, rotations again you can split. Probably you can have one course student if you want. You can have that one set of students coming in the morning. Other students will have this is what we do for phase 2. Our phase 2 students have their clinical skills in the morning. Phase 3 part 1 have their clinical skills in the afternoon to 4. So I have split. Morning there was something related to theory in my clinical department, phase 3 part 1. And evening there was clinical. If the other way around for phase 2, that we can have when we are voting questions, we will change it. Even the skills of utilization, what we do. All the students don't jump to the skills at the same time. We to see we have a proper plan timetable where each phase, each batch goes at each department, all the departments are given skills are within single. You can put a timetable. We can do it within our order. Yesterday we used to do 6 hours we can do maybe that has to come from university. What we can do is we will plan within the department where phase by students can be split. So you can manage accordingly. So no people who don't have clinical time, it's not my day today, I can handle both morning and afternoon. Somebody who has to secondary go. 50% of faculty can take care of the hospital and 50% of the students morning 4 hours, afternoon 4 hours, 50% faculty. Definitely, exactly one college, 2 hospitals.
Yeah.
Looks like that. Probably yes, we can plan with the
Yeah. NMC gives that flexibility to the institutions to work it out.
They have no regional lecturers, these many demonstrations. Start interest, you can from 8 to 4, we work from 8 to 4. 8 to 4, you can have it at any time. The theory possibly for the east and the limited faculty member have that work. Even that initially we tried as 125, 125, 2 people taking the same topic also. Then that also we can try. It's all in our hands. How the faculty cooperate to your plan, that's more important.
I think we've extended. Yeah, I think shall we close, sir? I think if there are no more questions. Yeah, thank you very much.
Please, sit, ma'am. Please, ma'am. Yes. Thank you, ma'am, for the wonderful talk. So we'll very soonly we'll conclude this session. Right. So there will be a small. Harish, I think. There is a parallel program going on, so photographer is engaged there. Yeah, thank you, Harish. So there will be a felicitation for the speakers of today's guest lecture. First of all, I invite our additional superintendent, Dr. Harish sir. Sir, plus can you come here? And I request our assistant superintendent, Dr. Pratima ma'am. Ma'am, please come here. Yeah, ma'am, please, ma'am, please. So first, yeah, I should say Harish sir, he is instrumental in bringing faculty from SRMC for faculty development program. I should thank sir for that one. Ma'am, can I invite Dr. Mohan Priya? Yeah, ma'am, please, ma'am. So I request Harish sir to felicitate her with a sapling. Bhavani. So as our Go Green initiative, we are giving saplings instead of bouquets.
Good morning, all of you. A few words. I think every good lecture should be followed by a good amount of discussion, which is well evident here. I think you have done more than what we expected from you, ma'am, and we are really grateful for accepting our invitation in short term and making this to happen here. And we'd like to listen from both of you more and more in future, because I have seen great amount of enthusiasm created by both of you in our audience. I think that is more than what is expected in any educational program. CBME curriculum, in my opinion, it is a newborn child of NMC. So we all need to nurture it, and we all need to see the difficulties growing the child and enjoy the child when you grow. So we all need to face all these problems, and I'm sure that there will be a lot of changes over a period of time going to brought in this curriculum, because again all these changes um, will be taken from all of us only, because NMC wanted us to see how actually it can be implemented. So it will we cannot answer every question in a short term. So we need to give some time to NMC also. So maybe a next decade they may come to a solid conclusions. So I think once again I thank both of you, ma'am. Thank you very much for having with us.
Sir, can you felicitate ma'am with this sapling? And I think Anand, ma'am, so can we? సురేష్ ఇది రెండు పక్కన పెట్టుకుందామా ఇది ఆపేయాలనుకుంటా కదా వస్తుందా